Good morning, everybody. My name is Ali Alvarez. I'm one of the faculty for today's workshop. We're really excited that you're joining us here today. Number one, because coming from California, it's very early for us. Thank you. We have a very packed 4 hours. We'll try to mix it with some breaks. We're gonna make it as interactive as possible. But just so you know, there's gonna be a lot of like engagement. So like you can hold us to that as well. These are the speakers for today, the faculty. We're also just grateful for several other faculty who is not able to join us here today for different other responsibilities. To kind of orient you for the day as well, there's going to be a handout. So take a picture of this now. You don't have to actually click it, just take a picture of it now. And then throughout the day, feel free to engage there. There's a tab there. One of the things that I learned recently is like you can add multiple tabs in Google Doc so that you don't have to have like multiple versions of it. And so then there's a tab there for like questions. There's a tab that I'll keep on monitoring throughout the day. There's a tab there for like insights that you've learned that maybe another person might learn from you. It's like, ooh, you synthesize something that we're gonna share. That's pretty much it. And the rest of our handouts will also be dumped into that later on once we're done with the day. So some logistics, bathroom. If you go outside, turn right, go all the way until the very end. You hit a wall, you turn left. You'll see some elevators on the left side. Just keep on going, and then the bathroom is all the way to the very end of that. So that's where that will be. Any questions so far? Great. So it's going to be a little bit loud. There's going to be some videos. There's going to be some interactions. But if you're not sure where you are, this is the MedEd Bootcamp, Be the Best Teacher, because we're competing with other like things, other meetings next to us. I think last year we keep on telling it. So as people come in, it's like, is this the MedEd Bootcamp? And then if not, they just go next door. But I'm so glad you're all here. I'm going to share the room now to Jason. If it's okay with everybody, we're going to be first name basis here because we're all going to be learning together. So just start us off. Thanks.
All right, thanks. I'm Jason Wagner from Washington, St. Louis. I'm going to be recording all of this today, and then we're going to use AI to create a summary of the meeting at the end of the day. So a little experiment with AI while we're here. So just know you're being recorded, it's just to give us notes and summary from all of this today. I like to start activities like this or events like this with a little mental activity. All right, thanks. Which reminds me of something I wanted to say too. When we're engaging in conversation, we're going to have you mic'd so that this can pick up your voice better. So I'd like to start with a little mental activity to share with your table. So the activity is going to be trying to explain something to somebody who's never experienced that which you're trying to explain. So I want you to share how you would explain the color red to someone who has never seen color. They see in grayscale, they don't know what color is, and you're trying to explain what the color red would be. So this will be like 3 minutes of conversation with your table about how you'd go about doing this. Go. We're going to share All right, we're gonna go about 30 more seconds.
All right, we'll bring it back in, and we're just going to take a minute to allow each table to just share how they describe the color red to someone who has never seen color. So we're going to start with this table. Just maybe talk about 3 or 4 things that you. How about 3 things? 2 or 3 things. Oh, I was going to have these guys go first. Sorry, Nick.
We described it as the heat of a fire. And then we said, what is it, aggressively loud or vibrant? I think were the kind of the 3 things we came up with.
And by loud, you mean like from a hearing sense or from like a garish style sense?
I don't think we defined it, but I think I would go with garish.
Okay. Okay. All right. Thank you. How about in the back? We just need it for the recording. So.
Oh, I need to turn this off, I think, too.
Can you hear me? Oh, there we go. Yes, much better. So initially, it was really the thought of logic of like, Roy G. Biv, what's the frequency of red? And I loved that that was like a very scientific answer. And then we also talked about the emotional side of it as well, talking about the passion, the love, and we had it was frustration, anger, using kind of the whole spectrum of what red can signify, which I thought was a neat combo of logic and science.
Okay, great. Thank you. And how about this table here? I have a feeling it's only going to let us have one mic at a time here.
We described it as perhaps comparing the taste of a cherry to a banana, distinguishable like that, and distinguishable. You see only the grace of the field such truly concrete. Tell the difference for everything else.
Okay. Back table, our faculty, do we want to share your conversation or do you want to share for them?
Carrie was the one who was
Can we get a
describing it.
Can we get a mic?
It's working.
As we're getting the mic, just so there's a few things, right, that I think some themes we're seeing here. You can describe it as a feeling, like the heat of a fire. You can describe it as emotion, the anger that rises up. There's one other category we'll see if you hit that I can think of.
Oh gosh. We talked about emotion quite a bit. We're like feelings corner over here. Sim had a good point about like it's like trying to make it feel like other things, like, oh, it's like a rose, like that's how that makes you feel. Yeah, like smell. Because we were trying to go to the other senses that people that don't have color vision would have. So like how does it smell? How does it taste? How does it like sound?
Mhm.
So we did loud sound, but we may let you down. I don't know.
In this table mentioned another thing they didn't say. You mentioned stoplight. So, red can be the sudden confrontation to stop versus green or blue, which can be soothing and calm. So you can think of it as more confrontational. That's another way to think about it as well. And so we do this activity partly to just kind of warm everybody up, get yourselves outside of the box of your brain, this confined thinking space, and think outside of the box a little bit. But also, if you think about what we're going to do today, we're going to talk about engaging learners and ways that we can engage learners. One of the things we have is the challenging learner. And a lot of times we think when you're having difficulty connecting with a learner and teaching them, we want to make it their fault. But sometimes it's because they just don't understand some piece of a concept we're trying to teach them. And as the educator, it's our job to teach the color red to somebody who's never seen a color before. And that's your learner in a difficult clinical scenario sometimes. What I'd like you to think about throughout the day, we'll maybe share at the end, is medically speaking or teaching wise, what's your color red? What's something that you find really challenging and hard as an educator or as a clinician? That one thing that just doesn't quite click for you. And if we have time, we'll share that at the end. All right, thanks.
You'll also notice that we're going to go through this with you. And so Jason was asking that table over there with the educators as well for the session of like, how did we come up with the answers? So we're learning with you as well. Throughout this day, we're also going to infuse AI because that's a thing that we have to get used to now. And so that's why we're doing the recording. Just so you know, for psychological safety, we won't be recording each of your table, especially during the time when we're debriefing some of the challenging cases, because we want you to be honest and really be truthful about what you're experiencing. That said, the goal of this is to also kind of make it easy for all of us, because some of you may be like typing a lot to like remember like what you're hearing from us. And the goal is like, can we offload some of those so that's at the end, so you have a lot more robust like note taker that we can use, that maybe you can also use when you're giving instructions at your own institution. Briefly, we're gonna cover AI, like 30 seconds if we can, just so that again, like as a quick primer, and then we're gonna do the gallery walk.
30 seconds, that's a challenge. It was 5 minutes, now it's 30 seconds. So just briefly, I think when we're talking about AI, what we're really talking about as educators right now are large language models, or LLMs. That's what we think about when we think about like ChatGPT, which is probably the most popular at the moment. Who feels like they understand how LLMs work? Just so I kind of have a sense of the room. Raise them high. We got a few. Okay, Ben, I hope so. So I'll just briefly define how an LLM works. I think a lot of times people have this concept that this is like a human brain who's learned and trained itself through a neural network, and then we retrieve information. It retrieves information much like we do, which is not the case. This is a random letter and word generator that creates sentences and paragraphs through analyzing the entirety of what was the internet last time that model was used. Generally, it's using the internet. And when you look at an LLM, the day it was made is the last time it referenced its library, and it started training on that library. So when ChatGPT 3.0 came out, that was a year ago. And whatever happened between now and then is not part of that GPT model unless you click on the little web browser icon and allow it to go to the web, the active internet, to seek information. The way it works, and this will be the last part I'll leave, is it would be like if I asked you a question and you went to the Library of Congress, and to start answering my question, you had to look through every single book in the Library of Congress and then come back and think the most probable thing for this answer to start with is the letter A. And then you had to look through the whole Library of Congress again to come up with your second word, the. And it's like, and they're like, the, and you go through that whole thing, and it's all probabilities. And if you look at the newer models now, they'll look back at what the answer it created and say, is this accurate or not? But again, that's a probabilistic answer. None of this is based on actual thought or logic. So when we go through AI today, you'll see this is why AI gets tripped up by simple things like mathematics or references. If something's artificial on the internet, it'll think that's a real thing, because think's the wrong way to say it. It will use it as a real answer, even though it's coming from a source that's suspect. So that's my 30,000 foot view on AI, all right?
Love it.
All right.
And we'll continue to infuse some of these throughout the day, again, because we want you to be comfortable as well using AI in education. In a few minutes, I'm going to ask Steve to quickly give us an information about like how the gallery walk is going to work for us. We're going to have 3 different sections here for us to use some of the collective wisdom that we've kind of accumulated. But before I do that, I just want to acknowledge Alexis is here with us, our MSA. She graduated medical school a few days ago, and she's starting residency at Emory. I think it's a big deal that we have now a new graduate medical student to actually learn about medical education with us, and she has an interest in med ed as well. Steve?
Yeah, so hi everyone. I'm Steve Psycho. I'm from the University of Central Florida. So what we're going to do now is at the tables we have pads of paper and pen, and we're going to have one of the faculty join each of the tables. Each table is going to have a different question that you're going to discuss, talk about. Someone is going to take notes on the notepad from the group. And some of the preceptors will have different information that they're going to share with you. Some of them, it'll be more of a discussion. And then after about 5 minutes, we're going to rotate so that you get to go to each of the tables. You'll see what's already at the table on the notepad, and then you'll be able to build from there. Okay, so we'll get everyone at the tables and we'll get things started.
Great. And also, I know I put in the names of the faculty here, but it helps to kind of like when you're doing sign out, it helps when you introduce your name, even though you know each other, so you can prime your ears to that voice. So I'm L.A. Alvarez. I'm a faculty at Stanford. You're going to hear all of us introduce ourselves.
Yeah, and Steve Psycho, like I said, University of Central Florida.
The model, whoa, hello. The model we're going to use will recognize our, this will work. I keep blowing it out, I think. So when we say our names, it'll reference us as we speak throughout the day. So Jason Wagner, WashU in St. Louis.
Susan Promise, Penn State Hershey. Sarah Williams, Stanford University. Yeah.
Let's turn that off. We're learning with you here.
Hello. Hi. Carrie Bales, University of Michigan.
Ben Schnapp, University of Wisconsin.
Sim Mand, University of Wisconsin.
And Jasmine Shaw, University of Cincinnati.
And I will ask our learners as we go through the day, if you're speaking for the first time, just say your name into the microphone before you start speaking.
Great. So we have 3 big tables. On this table, we'll focus on what do you do when you are gridlocked? How do you engage your learners? Steve, you're going to be on that table. This is going to be bedside teaching enhancements. And then on that table, we're going to be focusing on how do you develop educational alliance despite the environmental challenges. So Ben and team will be on that side, and Jasmine.
Can we ask one person from the
What's the next opportunity? Once they get
All right, I'm going to give you 1 minute to switch to the other group. So what I think what would be And so as the faculty switches to the other table, briefly read what has been written already and add into that information that's already been there. All right, 1 minute warning, and we're gonna switch the faculty again. All right, as you finish your thought, just make sure that when the new faculty goes to the next table, just read what's written already, and you're gonna build into what's already written.
Like advanced reconnaissance. Are you gonna be all the way here till Friday? I consensus all day Friday, but I was able to find but I was able to find not a direct flight, but a flight that left late enough to make it home, but it's land and take off again.
All right, 1 minute warning. Oh, sure. Do you want me to send? I love the engagement in the room. And you can continue adding more to this, because what we're gonna do is we're gonna put this on the wall. And then what we'll also do is we'll take pictures of the notes that you've created, and we'll add this in the notes, so you don't have to like actually take pictures. We'll make this easy for you. Sim is gonna be taking pictures for each of these, and we'll add in the final notes that you're gonna take away. This is also one thing that you can learn, right? So we're gonna be meta really quickly. If you don't know, if you don't have a lot of information about like a specific question, like it's similar to like think, pair, share, but it's also there's actually something about like thinking hats as well. So one group is kind of building onto each other. Thinking hats is a little bit more different because you're actually giving them specific roles. In this case, we have like the faculty kind of start you off, have some conversation, and then have the other group kind of build on to the answers that people are giving. So you can learn from each other, and it saves you a lot of time as opposed to imagine each of this will be a separate sections of the topic that we're going to be covering. All right, so congratulations, we finished the first part of this. Take a quick inhale and exhale. And then we're going to dive into cognitive load theory. So Jason is going to give us a download on cognitive load theory.
All right, who has some familiarity with cognitive load? Big high hands. All right, it's our capacity to retain information and function in an environment, and it impacts and affects the way we both teach and learn in a clinical space, in any space really, but we're really talking about the clinical space. If you look at the components of this, the intrinsic load is the basic complexity of the problem. Is this an easy thing to solve? Is this a complicated thing to solve? This image is structured in a simplistic fashion as if you're solving one problem, but we know in the emergency department, we're task switching between multiple problems simultaneously, but like in serial. And so you're functioning along your intrinsic load of maybe 6 or 8 different things simultaneously. The extraneous load is the load as educators that we put on our learners when we're trying to describe or teach a subject. So I'm trying to simplify the extraneous load of cognitive load theory by using visual demonstrations of how cognitive load piles up in your brain. So I'm trying to decrease the extraneous load. So you own this part as an educator. This is the part you can manage and control. Make sure that you're simplifying what you're expecting or teaching to your learner as much as possible. And then the germane load is the space that's left to work on the problem. So the more germane load you have left, the more time and energy you have to work on your problem. So then we'll go into the Yerkes-Dodson curve. So you may be familiar with this, may have seen this somewhere. So it's hard to not make this sound just a little pornographic. So it just sounds that way. This is the way the data was originally presented. But the way that this functions is, this is a transfer slide from Keynote into PowerPoint, so it's a little wonky, but basically, when you're on this end of the curve, you're not engaged in the problem yet. And we've all felt that when, say, it's a snowy day for those who have snow. You get a snowy Sunday and nobody comes into the emergency department unless they really, really have to, and the ED's, half empty, and you don't see a patient for the first hour and a half or 2 hours. You're down here on your curve. You're bored, you're not engaged, you're not efficient. You see the first few patients, you get off that part of the curve, and you get into your sweet spot. So in this sweet spot, now you're efficient, you're functioning, you're engaged, you're active. This is where we love to be. This is where we're at our best. But at some point, if you keep taking on work, you get into too much stimulation, too much work, and you fall off of the curve and you become inefficient. So your performance degrades. We've all felt this. We've all seen it in our learners. So what you want is to keep your learners in this sweet spot here by managing the load that they're managing in your emergency department. Now, the trick to this is that, well, that might be somebody's curve. Somebody else might have this curve. So they take more to be engaged, and they can function in a more chaotic or a more stressful environment. I like to say, like, this is radiology or internal medicine over here, and this is emergency medicine over here. Takes us more to get interested, but we function further out on the curve. What we love are learners who have a curve like this. They get engaged early, they stay engaged, and they're effective over a really long period of time, and then they kind of slowly fall off of this curve. So this is like the super doc, but you might have a learner who's this. They take more to get engaged and their curve doesn't last as long either. So as an educator, you have to be responsible for kind of recognizing this in your learners. And in our environment, we're a 4-year program. Our 4th years manage the junior residents and the students, patients in our critical care space. And they're constantly wanting the residents to take on more patients or the students to take on more patients. And you'll see a student who's like right here or a learner who's right here, and they want them to pick up that one more patient. And you're like, if they pick up one more patient, they're going to be over here and they're not going to be efficient or effective anymore. And so instead of managing 4 patients, they'll be managing none and you'll be managing everyone. So you pick up that one more patient so that they stay here in their sweet spot and we can effectively manage our patients. So this is a brief summary of cognitive overload, how it impacts how we work in our clinical environment. And then I want to just talk about one last thing, and it's a way when you become cognitively overloaded to kind of bring yourself back. And this is a breathing exercise. So I'm sure many of us have seen multiple different ways to do breathing exercises. There's combat breath, sniper breathing, breathing the box, or box breathing can be referred to. I like to do what's called stacked breaths. So this is when I just did this with a resident during a central line in a level 1 trauma who was pretty sick. And they were just flailing on this central line. It was a groin stick. And I just looked over and said stacked breath. And so I teach them all what a stacked breath is so they can utilize it in the moment. So a stacked breath goes like this, and we'll all play along. So I want you to breathe all your air out. And I want you to fill your lungs completely. A little more. A little more. And let it all out. So that's a stacked breath. The reason I like it is it's quick and easy, and when you're gowned up, nobody sees you do it. Breathing the box, it's very obvious. It takes a long time. A stacked breath takes 3 seconds and you're done. And it just hits this reset button that just sends this like cleanse through your body. And what you'll see in your learners is when the 2 things you lose when you become cognitively overloaded is your ability to think through a process. You lose system 2 thought. You can't think about complex things anymore, and you lose fine motor control. 2 things you really need in a critical moment. So when you see that resident struggling and they can't get that airway, it's because they lost fine motor control. And all they can use are their delts, their tris, and their biceps. So instead of their fingers, it's all this. And that's why the laryngoscope's going all over the place, and you don't know why they're not able to intubate. You just can't understand why they can't intubate. And that's where you just like stack breath. Get a quick stack breath in, and you'll see that fine motor control come back again. So that's my brief. I get all the like taking a 30-minute topic and doing it in 2 minutes. So cognitive overload and take home stack breathing to your residents.
Thank you, Jason. It was a very nice segue because now we're going to be talking about intubation. And one of the things that you can also do as you're teaching your learner is that you can do the stack breathing, but sometimes like, how do you do that when they're hyper activated and you're also hyperactivated? And so for me, when I get nervous, what I'm doing is I'm just slowing down the cadence of my speech, because by doing that, I'm slowing down my breathing as well. And you'll notice that at the very beginning earlier, I was really hyped up. I was really pumped, and I was very nervous because I'm managing the time, so I'm getting everybody moving. But at the same time, like I have to be aware of the cognitive load, where you're at, how engaged you are. And so now that we're reaching this sweet spot of people are now listening, right? People are now comfortable, and now you're talking. You've had some movement around. Now we're gonna bring you some more information. And so right now we're going to be talking about how do you teach somebody how to intubate when it's the first time they're actually doing it in person. So just kind of pause and think about that moment, right? They've done simulations already, but now you're the first attending. They're ever going to do their very first intubation.
How are you feeling, by the way?
So here are some objectives for this section.
All right. One of the first things we've talked about with the cognitive load is trying to get a sense of where your learner is. And
when you're thinking about your first-time intubator, where do you think they are in this 2x2 table? Right, this is adapted from Schwenk and Whitman. And when we're talking about competence, we're not talking about whether or not somebody is incompetent kind of in the usual sense, but along kind of this grid of competence versus expertise, all right? With a competent individual being able to do a task appropriately, and a person with expertise being able to do it through unconscious thought. There is very little cognitive load when you have expertise. You're kind of running on automatic, right? This breaks it down to competent or incompetent, able to do the task or not, or unconscious versus conscious. A consciously competent individual is very aware of the individual flow from one task to another. If this, then that. If this, then that. They're thinking about task lists, they're thinking about grids, they're thinking about checklists. They're going through it one task at a time. Whereas an unconsciously competent individual kind of goes from A to L to P to Z very quickly. And one of the best things they can do as an educator is verbalize their thought process out loud so that someone who's in one of these other grids can kind of follow along with them, right? A consciously incompetent ideally would be a med student who would be aware that they don't know, and know kind of, and you're setting kind of a psychologically safe environment for them to be able to ask the questions that they have. The ones you want to make sure you find are these guys, all right? Because they can be incredibly confident. And I want you to just think for a moment when you've been burned in your emergency departments, the ones that seem to be extremely competent or even maybe have expertise, but when you watch them in the room, when you get in and you do some direct observations, or when you're having a diagnostic conversation with them and you probe a little deeper below the veneer, you start to realize there are cracks, right? So you want to make sure you get yourself in a situation where you can identify the cracks so that you know that they're there.
At the same time, I think it's something that we can expect people to like, oh, just read about intubation. Just open Roberts and Hedges. They can read Roberts and Hedges over and over and over again, but they actually have to do something, right? They have to learn the mechanics of this, the holding of the blade or the ET tube. And so that transfer of tacit knowledge, something that we do very naturally now, and teaching somebody how to do that, oftentimes I struggle with that. That's why we did that icebreaker. How do you describe a red to somebody who's never really seen red before? It's the same thing. They've read about like riding a bike, but like actually riding the bike will take some serious skill transfer for them. We want to just bring in this idea of just-in-time training. This is not the first time they should be learning how to intubate, right? Just-in-time training is actually a reinforcement of a lot of things that they already have learned through simulation, through their reading. And so right now, let's just pause and think about that moment about intubation. So like, what issues might you encounter with a novice learner? This is the first time they're going to be intubating a human being that's alive, right?
And it'll stay that way.
And it'll stay that way while you're there. So what are some issues that you might encounter?
We have someone. Hold on one sec.
The wrong hand.
Okay. I just want to say it in the mic.
Oh, sorry, that your scope is in the wrong hand. Just
Yeah.
here. Put it in the right hand. You're like, no, that's not working.
I've totally seen that.
They won't pull up, they'll try to crank and it always.
Oh yeah, the crank. So the wrist movement, is it like more this or is this? Yeah. How do you do that in the moment, right?
He doesn't know what to preparate and where the stuff is in the recess room.
How do you prepare the equipment and stuff? Yeah, that's right.
Just timing, like with the chords are still moving, like when to really start, and then also teeth.
Oh my gosh, yes, the teeth.
Teeth make a great fulcrum.
I think the laxity that the jaw actually has, a lot of the simulated stuff is very stiff. So we're reminding them, wait for the meds to kick in.
That's a
Not
very good
supposed to be
point.
that stiff.
Yeah. I recently had an intubation and my res was like, I need more like succinylcholine. I was like, take off the C-collar. Right? But again, like for me, that's like very, I was like, I've had that experience before. For them, they're like, the patient is still very stiff. And I was like, not really.
Positioning the patient correctly and getting the patient to the end of the bed at the right height level for them, all of those steps.
We have one more here, and then I'll go back there.
I love it.
Just the nerves of being in the situation. Can't tell you how many times it's just like, you're gonna do this now, and then I just lock eyes.
Yeah.
With like, okay.
I mean, the nerves of the learner and also the nerves of the faculty who's going to watch this, right? And I think so. You've heard already some of this, and there's going to be many more, and we'll talk about that later on. But you can imagine how that environment, if you are not able to control your own nerves as an educator, if you're not able to transmit that information to the learner, the whole thing is just a mess. And what you were describing as well, it's like, it's not just the two of you. There's the respiratory therapist, the nurses. Everybody's watching you in this high stress, highly visible, high stakes procedure. So last year we did lumbar puncture. We're refining some of these tricks that we're sharing with you, and specifically in those moments. So high stress, highly visible, high stakes procedure.
So how is your anxiety level now? Is it peaked? Are you feeling it even through this just imaginary opportunity? Yes. All right. It is almost July. Yes. Such a difference between early June and late July. Oh my God. Yes. All right. So just-in-time training is where you take the moment before you go into the high-stakes environment to do a little timeout with your learner, and you have an opportunity to get yourself and them grounded. Right? You usually, in that kind of your first airway, it's not going to be your toughest airway, right? You're going to anticipate that it's going to happen. You have an opportunity to do a little just-in-time training, to check in with them to see where they're feeling like a little edgy. Like, tell me what are your thoughts? What are you going to do? Take me to your leader, right? Take me through your process, right? So they can talk out loud what their plan is. And if your program has got itself organized around some of these procedures, you can lean into their prior training. You can lean into their process. So if you've developed just-in-time checklist or just-in-time training around mastery learning checklists, you can really lean in on that and use that to be your guiding principles. How many of you use mastery checklists for your simulations? Okay, I see a few hands go up. I'm just gonna kind of put a plug in for review the literature on mastery learning checklists. I'm going to tell you a little bit of evidence around it, and then go kind of geek out and explore it a little bit and think about which procedural training and which communications training you could incorporate into your sim procedures and into your intern orientations to kind of really set a solid groundwork so that you're not trying to do all of this on your own every single time you're taking learners through procedures. Right, so this is a little bit of data. This is a meta-analysis done by one of the seminal authors in this field, who is William McGahey at Northwestern. How many of you have done any kind of mastery learning stuff? Heard of? Just search McGahey. He's kind of the father or grandfather of this field. And basically, what we have here is evidence that shows that mastery learning checklists outperform standard clinical education in pretty much every single procedural skill it's been looked at, all right? So this is hard data on clinical outcomes, all right? And this has been studied, it's continued to be studied in communications and delivering bad news and other complex, high-stakes code conversations, those types of things. This has been looked at in that. So don't try to reinvent the wheel every single time. It enhances multiple skills, and this is really critical, deliberate practice, which is an element of mastery learning checklists, is much more powerful predictor of professional accomplishment than experience or academic aptitude. So this is a very powerful technique, all right? And we don't have enough time to go into this, but homework, please look at this. All right, so before you go into the room with this learner to do your first intubation, your stress level, we've established, is high, right? So is this going to be when you let them do blind direct laryngoscopy? So you don't know what they're looking at, right? This is when I was a young faculty, right? There wasn't video laryngoscopy, right? So I was asking them, I was like holding my hands behind my back so that I didn't grab the scope, and I would be like, tell me what you're seeing. Right? Verbalize what you're seeing. Or like, okay, pause, quiet, quiet, quiet. I'm like, please say something about the chords really soon so that I don't lose my mind. All right. So video laryngoscopy has really changed things because you're seeing the same thing that they are seeing. And there exists a mastery learning checklist for video laryngoscopy that breaks it down into discrete steps so that it decreases their cognitive load. All right, and here it is. So here is the form. Somebody else has done this research for you, right? So these are the steps to video laryngoscopy so that you don't have to invent it all yourself. So that you can go back to this learner and say, did you ever learn this checklist? If they did, which parts hung you up? All right. Which parts do we want to drill down on now as we go into this room? And they may say, this is the part that I really want to focus on. This is the part where I've had a little bit of a trouble, right? And we look at these 4 steps, which is looking at the monitor and repositioning the scope to identify the epiglottis. So getting a good view, making sure I know where the tip of my endotracheal tube is and that it's not jamming behind the cords. Do you know what I'm talking about? Right? You could get in that slot that's too far back. And then manipulating it to pass through the cords. These 3 steps are really only 3, right? It's like, tell me about your view. Tell me about what you're doing with the tip of the endotracheal tube, and let's talk about how we're going to get it through. So you can kind of focus in on that piece so you're not trying to do the whole thing. All right. The thing that the mastery learning checklists don't do, because they're focused on doing the procedure properly and without a hitch, is your backup plan. So with every single one of these conversations, you want to have an explicit conversation about what is going to happen when things go sideways. And you agree on that before you even go into the room.
So that agreement is going to be very, very critical. And so one of the things that we need to at least have a conversation with the learner is like, who's doing what? What is my role here? Am I going to be the model? I'll do this, you watch, or you'll do this and I'll be your coach on the side. Or how do I then take over? Right? So I think that's very important for us to just include in the conversation. I lost my tracker. That's okay. The other thing is like making sure that we can communicate to each other in the moment. Again, high risk, high visibility, high stakes. And so calling out the learner in the moments when you're nervous or they're nervous, it's just going to get them really more agitated. And that's the last thing we want. So sometimes I'll be like, just focus on my voice. I know there's a lot of noise in the background, but I'll guide you through this, right? Just being very clear with them and then being very supportive. Some things that are very important as well is these non-verbal communications. And these are important to just establish before you even go into the room. So one of the things that we can do is, Sarah, so this is outside, right? So I'm going to call her Sarah. Hey, Sarah, when I look at you in the room and I nod, that means you're up. You just go. So nobody else will hear that. Otherwise, like the more I talk as the educator, the more everybody's like, is this the first time? Right? And that happens. But if we can minimize a lot of that in the room, that can be really helpful. Another thing is like, how do you then pause somebody? So it'll be like, when I raise my hand, just pause and look at me. If in the moment, again, cognitive load theory, in the moment they're so nervous and I'm like doing this and they're not getting my attention, I'm not able to get their attention, at least figure out an established way of getting their attention. It might be, is it okay if I put my hand on your shoulder? Or when I put my hand on your glove, that means you're going to pause and then just look at me. Those are key things that will be very, very important. Any other things that you may be thinking right now? Okay, we'll give you more. So you heard us earlier. I was like, hey, I called her Sarah outside the room. In the room, one of the things that we can also do is when I say Dr. Williams established that she is very competent, she's done this, she's going to be very good at this, I call her Dr. Williams because it reinforces to the entire room that she's going to do this procedure. But when I say Dr. Sarah, her first name, she will pause and she'll look at me. I do this all the time with like lumbar puncture or things that, so the patients won't know that I'm trying to get their attention to stop what you're doing and you just look at me. And then again, there might be some areas for the procedure that's it's just a natural way to stop. So one of them will be right before you, right after you position the patient, you just look at me again. Right before you administer the medication, you look at me again. And then right before you're actually going to open that jaw, just look at me again, because sometimes time just like stops in my mind. I'm like, I'm ready. But like you just literally push the paralytics. You got to give it some time. And I get nervous sometimes and I also lose that. So that's very important.
And I need my healthy dose of affirmations from LA. Right?
Yeah.
So if I know I'm going to get one at multiple times during the intubation, I'm going to feel better.
You've got this, right? Some verbal affirmations will be very helpful as well. Yep, you're doing great. Just go step by step. And if you really need to take over, just ahead of time, establish that. There might be a time here that I'm going to be taking over. It's not a failure. It's just that at this time, the patient is paralyzed and I need to just control that airway. And we'll talk about it afterwards, right? But establish that at the very beginning, because oftentimes the learners are so nervous that you're going to take over, you're going to take away that procedure from them. All right, so we talked about like other ways of like stopping. So how do you then redirect? So let's do this like scenarios. Ooh. So I heard the example earlier, like, so you're about to intubate and Dr. Williams, they're doing wonderfully. Okay. One thing that you can, they're paralyzed now, right? And so they're doing this. One thing that you might do is to use your left hand to hold on to that blade. Okay? That's it. It's very simple, very direct, right? Instead of like, what are you doing? Like, and then you're like, in your mind, you're like, they've never done this before. But you've already established that. They've never done this in real life and they're so nervous. Sometimes they're shaking, right? Okay, so now you see Dr. Williams is trying to intubate and they're like looking at that, like that step earlier, right? And they're really struggling to pass that tube. Dr. Sarah, here's another way that I've seen it done before. So instead of holding the ET tube like that, or the stylet like this, again, it's a rigid stylet. The way that it's built is actually to enter sideways and then just use your wrist. See the difference? So again, very calmly, I'm giving her some guidance, as opposed to like they're doing this and they're just keep on jamming that thing, and like the anterior part of the airways is getting like traumatized. It's like, all right, let's pause, let's just guide it from the side, and then here's another way of doing it. You can also just give them some tiny cues, like, hey, check the positioning of this, or anything else that you would change. So like as she's trying to do this, you ask her, it's like, I can see that it's really hard to like pass that tube. Anything else that you would try to do? And then they're like, it's like, oh, one way that I've seen it done, especially with like glide scope, is to just go sideways. And then again, if they continue to struggle, this is when you're like,
Let me show you.
Yeah, Dr. Sarah, let me show you how I would do it. So now, let's pause here and just kind of think of the first time think of the time when you taught somebody to intubate for the first time. What are real things that you've seen, that you've encountered? Please.
I think patient selection, because I think that, once a resident fails at something, it's going to be that much harder every time. Yeah. So I think the key is making sure to select. You don't take the 20-year-old asthmatic who's crashing this very moment. This is life or death. So, a code where the patient is just going to get 1 or 2 more rounds of epi and they're close to dead already, or a patient where you have a lot more time. So either end of the spectrum, I think, is a better choice for that first time intubation.
And you get to predict a lot of that, right? You can assess them from the very beginning
Yeah.
and even like warn them. It's like, this is going to be a very tough airway. We can
Yeah.
give you like a runway here. You can start, but just so you know, if I hear the pulse ox drop, so like establish that at the very beginning, or just set it up as like this. Like I remember this like a few months ago. Like the intern was like so excited. It's like, can I intubate this patient? Like it was like a trauma, right? Like massive like facial trauma. It's like, I love you, but we have not worked together yet. I'm gonna give this to the fourth year. Period. Like there's no explanation in that moment. Fourth year intubated, and then we had a nice debrief afterwards. Like, these are the things that it'll be very hard to explain to you in front of everybody. But I love that patient selection. Anything else that you've encountered?
I'm a current resident for context. I'm a PGY2. When I was an intern, nobody asked me what number it was for my first one. And, it was for a trauma. So we're like going back quickly. They're like, "There's a patient here now," and you're going back, and I'm putting all my stuff together. And you know how to do it. But I think it's good for someone to know that there could be issues arising if it is your first time. So I was standing at the head of bed going like, "It's my number one." Like trying to let them know without being super obvious and bringing it to attention to everyone else. So it takes an extra 20 seconds to just say like, "How comfortable are you? What number is this?" Because I think even that singular statement can really help set the scene up for success.
I love the phrasing of "how comfortable are you." My worry with how many times we've done this is that they exaggerate. Kind of like, "How often do you drink?" They're like, "I don't drink." And then you're like, "Alcohol was at 500," because they don't want you to take that away from them. And again, it's important to align that from the very beginning. Like, I want to work with you here. I want you to have like first pass success. Here's how we can do it. I actually say that I don't care if this is your first time. Just let me know so I can actually work through that with you.
I'm going to just take this back to the Yerkes-Dodson curve I showed earlier.
Yeah.
As you gain experience, you start to develop heuristics and you chunk your knowledge. And so you have experienced people can fit a bunch of chunks under that curve and be effective still. A novice learner, all the things that go from setting up the airway to intubating and managing the vent overwhelms them. So you have to decide what component are they learning today.
That's right.
And if it's just the mechanics, then it's just the mechanics.
I think one of the things that's helpful is to remind them of their safety net.
Yeah.
That, hey, if you don't get first pass success, that's okay. We have this BVM.
Yeah.
We're going to bag them. Like, you can do a second try. I think it helps calm their nerves a bit. They don't put so much pressure.
I like that a lot. And again, like that you're there the whole time with them, right? And you better be there the whole time with them, ready to take over. And so these are just things that we kind of highlighted already. How do you manipulate the ET tube when you're passing? Or how do you hold the laryngoscope?
All right. So you've done the procedure, and now it's time for you to kind of debrief. When do you debrief? How do you debrief? I'd love to hear kind of what people's kind of usual kind of approaches. Do you do it kind of in the room? Do you do it outside of the room? How much time do you kind of allow to pass? How do you approach it? And are there scripts that you've seen people use or that you've used yourselves that are helpful to you? Maybe discuss it at your tables for a minute first, and then maybe one person share from each table. Does that sound good?
Should we pull the video now? Because this is it, I think.
We can go on to the we can go on to the case. It's actually part of this set. I added it to the set. It's all here.
Nice. I'll go back to this one.
Do we want to go from the bathroom break before we go to the next step? It's been an hour.
Yeah, we can do that.
Yeah?
Yeah.
Like after this, after we debrief, have you
1 second.
come back at 9:30? Yeah? Okay, so like a 5 minute, 10 minutes? Okay. All right. So I see a lot of really great conversation happening at each table. I always hate interrupting that actually, are we ready for one person maybe to share out from each table? We have a volunteer? Or someone's going to be voluntold? Okay, who's ready? Who's ready? Yes. Oh,
We were talking about how a lot of times, whether it goes well or not, they're going to have a lot of anxiety and be focusing on the things they didn't do. So we sort of let them emotionally vent. And then they might start talking about all the things they did wrong. And you might say, okay, we can talk about that. But what do you think went well? What did you do well? And in almost all cases, unless it's a complete disaster.
yeah. Yeah, if you get curious,
You can
with
find
them-
one thing that they
Right.
did well.
Right. If you get curious with them about kind of their perspectives, they'll often be way harder on themselves than you ever would have been. So then your job in that is to maintain their self-confidence. And they'll do the kind of the toughest part of the debrief themselves, right? So that can really rescue you, and then you come in as their support network. So thank you for that. Yes.
I think we're supposed to introduce ourselves. I'm Robin. Our group really talked about multiple things, and I think one was the debrief almost needing to happen right after, almost that quick analysis, unless there's a lot of correction, and then taking it outside the room. We have a little bit of a walk from our recess to our pod,
Yeah.
and so mine tends to be on the walk, and then we stop. I pull the residents aside if we still need to talk. We kind of go into this other space.
Love that,
before they go
knowing the
back into room.
geography of your space and where good places to hide are.
And so usually when I see them walking in the room, I'm walking with them, because we need to put orders or things, but that tends to really help. And then I really liked, if you want to explain, I thought you could.
Yeah, I think I'm Keith Ongadden from Wayne State. We were talking basically about just the, I termed it like hot wash, I think, but that immediate debrief after the event those learning points are a little bit more salient. And then I was just mentioning that some places that I've worked at have automatically started recording the intubation. As soon as that glide scope or video laryngoscope turns on, it's recording, so you can review that, and those are very actionable points. Like, okay, your blade was here; it probably should have been a little bit higher. Here's how we'll go through the motions, and that mechanical feedback and video or at least visual feedback is helpful.
Yeah. Kind of what I'm hearing there is kind of normalizing feedback conversations, having the debriefs happen on a regular basis so that it's not kind of a surprise, that it's most of the time it's happening, not every now and then, because if it's every now and then, it becomes higher stakes. If everybody's being videotaped, then it becomes normalized and it doesn't become a thing, right? So setting in place some processes within your institutions to make it kind of an expectation that conversation is going to happen, and then creating a way to do it. Love that. The pause.
I can start. You talked about letting them make their own debriefing, like letting them work out what went wrong, probably makes it longer lasting. And we talked about giving them the possibility to give a feedback to the teacher too.
Ooh, bi-directional. Having it be a conversation.
Were there other points?
I used to see what's one thing that I could have done differently to make this procedure easier for you, right? So it's not like, how did I do or what could I do differently? Like, what's one thing? Make it very specific. I'm channeling David Manthe here. This is a great moment to really make sure that you ask them also to commit. What's one thing that you're going to read up about from this procedure? What's one thing that you're going to do more next time? What's one thing that you're going to do differently next time? Just ask them that one thing. I heard about this like possibility of, and it's not a possibility, it's actually very real. The learners are going to be so tough on themselves. And most of these airways are going to be fine. You're going to be able to intubate them. And so I take these, like especially intubations, as opportunities to highlight amazing and awesome, right? We do a lot of M&Ms, like the bad stuff, like things that go some not so great, right? But the ANAs, like this is a great moment to highlight, like when you actually secure that airway. And so I tell them, like, hey, when they're being tough on themselves, you got that airway. This is what it feels like to actually save that life, right? We don't often do that because we're often like, we're going to go from one room to another, take care of other things, right? It's okay to also just pause and let them know this is, and like, so I'm getting goosebumps, right? Like when I get goosebumps, I tell them that. I was like, hey, I'm getting goosebumps moment. This is how it feels like to actually did this right, because they're going to be so tough on themselves. So this moment, we're going to take a break. We're going to give you a time to go to the bathroom, grab some water, come back in 10 minutes. So it's, what time is it? 9:26, 9:36. We're going to start because you're not going to want to like miss this. Now we're going to talk about like a real life challenging airway, and we're going to learn how to give them feedback in the moment. We'll see you at 9:36.
Someone's getting paralyzed. You just don't know.
All right. Good. Yes. And you'll restart it again when it's. Do you need me to do anything with that? Okay.
This one, and we'll start a new. It's funny. It uses its GPS to decide where you are. We're at the municipal court criminal division right now.
It knows. It knows our intent. All right.
That was motivation. That was motivation.
All right. So do you wanna go through it and just kind of get into your mental space?
I guess my question is, how much time do we have to video? Are we running? Should we not worry about crying? I feel like we're about right on time.
I think we're about. We're 15 minutes behind.
Okay.
We're about 15 minutes behind.
Okay.
So let's think about our timing.
I would say I feel like a lot of the cut can come from the scenarios, right? We said saying 15 minutes or just even if we have like 20 or 30 minutes, I think that would be sufficient. I agree. Let's do it. Let's not even carry it. My worry is that presentations take about 30-ish minutes.
They probably won't be back from the bathroom until 40.
Oh, really?
Would be my. They're probably going to be 10 more minutes. So if we start at 40, and we do tell Ellie when he needs us. Can you ask him when he needs us to be done?
Yeah. I was gonna say, so what can we do for the video? 'Cause I know we had to talk about the pair sharing. I might just have them just note their reactions and then skip the sharing at the table. Or do you want them to still share their thoughts?
I think they.
Because we kind of already touched base on like how would you approach
I think that this is so powerful that kind of recognizing how triggered they are.
and discussing with the table.
And discussing it for like a couple minutes. Yeah.
We can do that.
We'll flex a little bit
20 for the whole thing.
for the whole thing.
We're only going to have 40 minutes.
Huh?
That's only 40 minutes.
No, 9:36.
No, they're going to be back at 40. They're not going to be back.
Oh, okay. Well, then I'll keep on extending it.
So because 10:20 would be only 40 minutes from 70.
That sounds like I think the presentation's gonna be
Yeah.
the most
So we want to keep the discussion around the video at like 5 minutes.
I was just telling her it might just be 5 minutes, just like debriefing to you how you're feeling. Because I initially wanted to have them start to think about what they've been saying during feedback session.
Yeah.
And they can still touch base.
What is
negotiate?
Well, so we can have this go long or short, but ideally, we don't have many slides, but we want to make sure we
The
have
conversation.
we have about 3-4 minutes for the video.
Sure.
Ideally 3 or 4 minutes for the video. No, the sound is working. That's good. And then we want them to kind of emotionally debrief that, how they're feeling after the video.
Why don't we stick with 10:40?
10:40 is good. Yeah.
Okay.
Does that give you enough time? Because that cuts us by 10. Or if we can get done before then, we will.
Yeah.
But
I know we're not because we're.
But if we can do if if we can, now we have 60 minutes. We'll talk and see if there's a way we can shave off a couple more minutes. But okay, all right. So if we haven't, okay, okay. 10:40.
10:40.
Oh, 10:40?
You just said 10:40.
Did I say 10:40?
You did.
10:40 it is. See, I'm blind. Very close.
But we'll try to get you more. But, okay.
I was gonna say, I think
So
I'll see if I can cut down my challenges and give you that, because I think that's a really important thing to hammer home too. We've
Yeah.
given you all this wonderful stuff, but let's bring it back.
Yeah.
So I was planning on going like 5 minutes. So it's on.
yeah. All right. So let's think through this. Let's think about the kind of all right. So if we give them about 2 minutes for the debrief after the video.
My part is not that long. It's like,
Yeah, this will go pretty fast. We're gonna role play it. We're probably about 20 minutes to the. All right, probably about 20 minutes of a talk. We'll probably be at 11
I'd probably say maybe 30 with all the discussion.
with the discussions
And
and
like 30 minutes for scenarios.
for the scenarios.
Or 20 minutes for scenarios and then 5 minutes to go regroup.
20 minutes for scenarios. So when we break for the scenarios, we can touch base and say, where are we at?
Yeah.
Because what we can do is we can have them talk about each scenario for 5 minutes.
Yeah.
Or we can have them talk about each scenario for 10.
Yeah.
So when we get to the scenarios, we'll figure out kind of where we're at. And if LA is, if we can get him 5 minutes back, he'll be super, super happy. So,
I want to be in his good graces.
yeah. So it's just, because there's been like a little bit of run over in several places. So if we can kind of get them back on track. But I think, if we go through the challenges, we'll just kind of be expeditious in each. And then when we get to the scenarios, we'll powwow and say, do we need 5 minutes, 10 minutes?
Yeah, we'll just get them started.
We'll get them started and we'll see. Okay.
That sounds good.
All right, perfect. All right, I'll transition us out and then I'll step back. And then I can play the video. I can just do the I can make sure that's going. All right. We're good. Do you guys need to go over the manual?
No, I did already. I did my math already. That was a lot of fluids this morning. Yeah.
Insufficient. But there will be more. Welcome.
I know what we want to
I still see like all of them feet. Signal me when you got your quarterbacks. Not us. Yeah. For this next part, it would be really helpful if you got into the handout. So if you grab the QR code, it's the same QR code as before. There's a tab, so if you go to the bottom on your phone, you'll see that there are 8 tabs. Let me know if you're finding it okay. And go to the tab that says adapt. And let me know if you're able to find it. Okay. So. It should look something like this when you get there. So what you'll do.
Oh, yeah.
You don't mind?
So if you go to the handout.
if you want to go on to the actual thing, and you'll say yes. And then at the bottom, it will say something like objectives and timeline. Click on that. So click on this thing at the bottom. It says objectives and timeline. There. And then you'll click on that, and there'll be one that you kind of scroll down that says adapt, coach, approach, giving feedback. That's where you want to be for this part. All right. All right.
Should we get is everybody back or should we just get started?
Still missing a few people, but I'll go ahead and get us started with just kind of the transition, and hopefully our colleagues will come back soon. So one of the things we talked about before was kind of this, when it comes down to it and trying to normalize feedback and kind of these concepts, they're great in theory, but in reality, they can be challenging, all right? Which is why it's not happening as much as we want. We're going to introduce you to an approach to feedback that will, I guarantee you, change the climate around feedback if you start applying it on a regular basis. And we're going to show you an example of how to integrate it into a very difficult, challenging feedback conversation. So if it can work in this, it can work anywhere, all right? So, because we want to think about proceduralizing feedback. Right, we just talked about mastery learning checklists around kind of complex communications and procedures. We can do that with giving feedback as well. And basically what I'm going to give you is a checklist around how to give feedback. All right. What we're going to do first is we're going to watch a video. This is a real airway on a real patient I'm going to let you see it. Just kind of watch it and let us know what you think at the end. Okay, ready? And please keep this kind of M&M rules around kind of what you're seeing here, please. Thank you.
He's deep circulating right now. Pull her cheek. Pull her cheek, RT. All right, let's get the both of them. Are you through? I think so. Yeah, bag. I don't see exchange. If she was hooked up to it, I didn't see any exchange. I did not see any CO2 exchange on the vent. Let's go ahead and get a bag. Get a bag, glove mask, bag right here.
How much would you like pulled up?
We're gonna need a big
We're gonna do bougie?
She just wants to know if you want to style it or not.
You're gonna do bougie? Okay. All right. We got another. Step over. Let's get rid of bagger again because that's not.
What do you want to do?
No, just keep it like that. As soon as we bag, I want to stick it on there because I have to change over the end title.
All right, 2. But I got you. We got that thing.
We're going to pause for a minute and let you guys kind of debrief with each other around your tables about what's going on with you right now through the lens of the attending and maybe through the lens of the learner. And then invite you to share one observation of your own without sharing the observation of your colleagues that you're willing to share. Okay, in the group afterwards. Everybody okay with that? Okay, right. I don't know, Jason, maybe not record this part. What's that? Could we not record this part?
I think it might be.
Yeah, we'll pause it. Yeah. All right. All right, thanks.
Thank you.
Every time I watch it, it's still like
Just in and out. It doesn't, you know, some things get shorter more times you watch it. This gets longer and longer.
It's just a no corrective action.
I know.
No one's saying
Nobody said it.
attending in the room.
Yeah.
I debated blurring his face too.
Yeah.
He's not as vulnerable. But it's not just
Yeah. You can see all the C-Max.
Do you want to share nails at the top of the room before they share?
Sure.
All right, I'll let you do that because that's important. Should we bring him in?
Yeah.
All right, let Jason.
Introduce Jason or
No.
feedback.
All right, we'll come back to have a discussion from what your groups talk about. So I'll just let you know. So this is my airway video. One of the things I do when I work any shifts where we have airways is I record the airways, and I do it as like play by play or like playback, like you wouldn't say, you know, reviewing football tape or something like that. What you find is if I ask that resident half an hour later, what were you thinking while that laryngoscope just sat on the left side of the patient's tongue for a minute? Their answer would be, I don't know. They don't remember any of this. And only by recalling it and going through it can you kind of consolidate what happened in the moment with them when they're stressed like that. And this wouldn't, and to sit silently and record this while another attending is managing the airway is really hard. But and that's the origin of this. And I have, you know, dozens of these. So.
Yeah, and I really want to thank you for sharing this. I think it's very, very helpful to see something real.
And I guess I should add, that's one of our senior residents. So this is not a novice intubator. This is a person about to graduate.
Again, kudos to Jason for just being so quiet in the background. Like I can see each of you when I was looking around the room. They're like, you want to do something, right? And so in the moment, I can imagine you're going to say something as well, but like that restraint, that generosity to just allow things to kind of happen, it was impressive.
So, this can be overwhelming for a number of reasons, and we don't have to have all the answers to solve this right now. That's part of what we're going to go over, but I did want to go around to everyone's table and just share sort of like any like response you had to this. So, is it about the learner? Is it about the educator? What made you uncomfortable? Like, what did you notice? Like, what is an observation that stood out to you the most? Is there anything from this table over here that?
Like nobody's saying anything. They leave the resident on an island, and I feel like they just don't say anything while he's like barely passing the lips and like tongue, and you're just like, You know, if you just say, hey, I think you can go a little deeper, like you would have fixed a lot of problems a lot faster. Like
Yeah.
all it takes is a small phrase.
Part of this too is we muted some of those conversations too. Yeah. I think there's like the like I think there's some of that to kind of protect a lot of the conversation.
Yeah, we also mentioned like the silence. One of the things I said was just like one of the worst things as like a learner is like there's just silence and then there's beeping, and you just like are trying to figure out what to do next, but you don't want to like cause like too much of an alarm because who knows like who else is around. You don't want like to make the situation like frantic.
In the back.
We talked a lot about the silence too, and I think like it was very obvious that the learner got stuck and didn't know how to readjust. And so like something that came to mind that I think would have been helpful to break the silence is asking a prompting question and saying like, what's going wrong right now? Or like, what do you feel like you need to do differently? Because once you're in there, it's easy to kind of just keep doing the same thing over and over again and being very focused on getting the job done. But, you know, sometimes you have to come back out and reset again.
Thank you guys for sharing. So
We could go ahead and start recording again then, Jason.
yeah.
It takes a while, right, to be able to give them that space to be quiet versus like the me when I was very first attending, it was like, what do you see? What do you see? What do you see? No, you're not seeing it. You're not seeing it. Da, 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 da. And then they get riled up even more. So like, how do you find that balance? So hopefully we're going to learn from the team here.
Yeah. So if we think about all of our emotional, visceral responses to this, it's like can be daunting to think about what would it look like to transition into giving someone feedback about that. So we want to talk about feedback in general. So it's interesting that in our last case, we referred to the end of the encounter as a debrief. And so we've started to think about like, is feedback itself like something people are afraid of? Is it a dirty word? Because I feel like feedback, when you say that, it evokes a lot of negativity subconsciously. We can think about times when we've been learners and we may have gotten tough feedback. And then now, as we move into roles as educators, we think about moments where we've had to give constructive, hard feedback and how that feels. And it can feel really bad. We may have even gotten feedback about our feedback, that our feedback wasn't good feedback. And so we want to talk about all the emotional responses to this and how it can be anxiety provoking to give hard feedback, how it can be anxiety provoking to give feedback in general. And we don't want to take the emotion out of that, but we want to give you a more like systematic, logical approach to doing this. And so before we go into the specific model that we want to go over with you guys today, we just wanted to talk about some best practices with feedback in general. And so I really recommend, I put it in the document that's shared with you guys, but there's a 2023 consensus document from CORD on feedback best practices. It's like jam-packed with a lot of good things. And so starting from a like 30,000 foot generalizable view, there's some features of feedback that all feedback should have. So importantly, feedback should be clear and it should be specific. It should be timely and it should be actionable. And what this looks like is identifying as specifically as possible actions that the learner could build upon next time. And so you don't want to make big sweeping statements about your learner's character, about their like being, because that's going to one, feel really bad, and two, it's going to be really hard for them to improve and act upon. So instead of calling someone disorganized, that's going to be really hard to hear. That someone's going to respond to feedback that they're disorganized and say like, how, why? You want to say, hey, I noticed that during the shift, you don't seem to have a method for organizing your patients. And I think that's really slowing you down when you're trying to go to run your list and you don't even know where to start. And so I want to talk with you about a way you can organize your patients. That is actionable. It's not about them, and it's specific. And so it's easier for them to work on. In the next slide, I'm going to talk about ways your feedback can be timely at different time points. But in general, the best practice is to give someone feedback as close to the encounter, the incident, the question as possible, so that you're not giving feedback to someone like weeks or months later. And so We've already talked a little bit about in-time feedback. So this is most amenable to procedures where someone's going through the steps of something. And as they're going through the steps of something, you can give them suggestions, tips. Ellie had a lot of good prompts, suggestions for in-time teaching. And this is really amenable to procedures. There's types of learning, types of clinical situations where this is less applicable. And so if you're watching them take a history, watching them run a recess, that's really hard to give feedback in the moment. And so you may need to move to a different type of feedback. And so in general, you may have heard of formative versus summative feedback. So formative feedback is something that's iterative and you're giving it along the way to help a learner develop. And summative feedback is at the end of a learning time period where you're making an assessment on someone's achievement over that period. For us, the way that makes the most sense is during the course of a shift. And so formative feedback may look like giving someone feedback about their plan and their assessment right after they've presented a case, whereas summative feedback at the end may be overall on their gestalt and their decision making. And so there are a lot of different models for how to give feedback. There's a lot of great models for how to give feedback, but we're going to talk about one that we really love because it's really collaborative between the learner and the educator. And I think it best speaks to all of these thoughts and emotions and context to giving feedback. And so Sarah is going to talk to us about the ADAPT model.
Thank you. I'm very excited to share this with you. How many of you have heard about ADAPT before? How many of, I'm seeing some hands go up, but not many. Okay, so yay that some people have heard of it. Some of you have heard of it, so yay, and now many more of you are going to learn about it. And so for context, I'm a professional coach as well as an educator, and what this ADAPT framework allows you to do is to take a coaching approach to your feedback conversation, and it allows you to be a partner with your trainee around what you're going to be giving them feedback on, and it allows you to develop a trusted relationship with them that allows you to get into really tough feedback through a different lens and through a different context. I want you to think a little bit about when you are getting feedback from someone. All right. I want you to imagine the last time you got feedback from someone and it was not welcome. Is that readily available in your memory? All right. It may be that the individual that you got the feedback from wasn't someone that you thought was credible. It may be that the feedback was a surprise and it was unwelcome, that you weren't ready for it, that it was mistimed. It may be that the individual that you got it from was not someone you trusted, that you did not trust their intent, you did not trust that they had your best interest at heart. It may be a combination of these things or other things. What ADAPT does is it lets you get rid of all of that, all right? It's evidence-based, and it's actually included in the ACGME best practices around feedback, so it's important to know this. And it's basically a master learning checklist about feedback. So let's kind of dive into this a little bit. At the beginning of your shifts, start normalizing the fact that you're going to be giving feedback, right? At the beginning of the shift, say something like, all right, so I'd love to give some feedback at the end of a shift, but I want to make sure it's feedback that you need and that you want. So I want you to tell me a few things that you're working on that we're likely to see, that you want me to come in and watch you do, so that we can debrief about it in real time later in the shift, right? And whatever they tell you, have this conversation at the beginning. That took 20 seconds for me to say that. Whatever they tell you, go for it. Don't judge it. Just be like, okay, they want to learn about EKGs, and they're going to throw me a softball first, all right? That's fine. You watch them do the thing that they mention. You do some feedback the way we're going to show you around that thing. And then what ends up happening is they're like, actually, that was really good. So we're going to now drill down on something else that may be a little harder. And you develop a relationship with them so that you now start getting permission to observe things that maybe they didn't comment on. And I also noticed this. Would it be okay if we talked about that too? Yes. Right? So then the conversation becomes something that's more directed from you than from them. But that's after the relationship is established. All right? So with that in mind, this is adapt. So there's 2 steps before the actual adapt acronym that are really important, which is the preparation, the conversation that we just had around what are we going to give you feedback about at the beginning of the shift. And then they do the thing and you watch it. You have a direct observation. My recommendation is that once you've seen 2 or 3 things, unless it's a critical airway, once you've seen 2 or 3 things that you can give them some constructive feedback about, you step out of the room so that you preserve their autonomy, so you don't have to worry about that. And then you start the adapt, which is the first ask. Ask the trainee, how did that go? That's when you get some insight around what their perception is and their insight around what just happened, right? You can see how deep they can go. And they'll often just beat themselves up and you're like, okay, I don't have to ask much more. They've already done it themselves. And you can have the discussion around that. If they don't go the direction that you need them to go, you can say, okay, yes, I also noticed X, Y, Z. And then you have a discussion about that. The next ask is around clarification of the discussion. What comes out of this that we just talked about, and then what are next steps with the plan together. All right, so in your handout is the reference to this. The module has evidence behind it. There's a study we're going to tell you about, but it also has a complete faculty development slide set, and it has a learner development slide set, so you can show it to your residents so that they know their part in this conversation. That's a game changer. Ben.
Obviously lends itself to I think this obviously lends itself to a very concrete interaction like an intubation. Can I do this same framework for, like, let's say a whole shift? Like, hey, how do you feel like that whole shift went? Because I feel like I'll do that sometimes and I'm only medium satisfied with the responses that I get back.
Yeah, I find it, kind of getting back to best practices about feedback, the more specific you can get with this, the better it performs. And we're gonna we have a scenario where we have someone who says something like that's vague, that we're gonna kind of have you kind of play around with, so you can think about how you're gonna parse it out to something a little bit more specific. So we have something for that specifically.
Awesome, thank you.
You're welcome. All right. All right, so you want to tell me what we're gonna do?
Yeah, of course. All right, and so right now, Sarah and I are going to role play an adapt scenario. So we're going to bring back the difficult airway case that we just saw at the beginning of our session. And we're going to give an example of how using the adapt model might help debrief a difficult case like that, and how that interaction would look like, and how Sarah, as the coach or the faculty member, and I as the learner, how that might play out in real life, and how Sarah might pull out some learning tips out of a very emotionally charged case.
Yeah, so we're going to the airway video that you saw, and we're going to show you how an adapt might work. You can obviously play around with this, but we wanted to give you a concrete example before we broke you up into groups as to how you might apply this. So, is this going to pick
up both of us?
Normally we would dance around the room, but we want to make sure that the AI gets all this, so we'll just stay right here. Okay.
All right, we'll see.
All right. So just to kind of preload this, kind of at the beginning of the shift, you mentioned that you were ready for a tough airway, and so we made sure that we realized this patient was going to be a difficult airway. You indicated that you were ready, and so we gave it a shot. Okay. So so how did that go?
Honestly, not good. It was much, much harder than I was expecting.
All right, tell me more about that.
I just got very overwhelmed. I think I couldn't find the chords, and I'm normally able to find them pretty quickly. And when I couldn't see them and seconds were passing by, and I don't know, I just haven't had a tough airway like that before. And so it was really hard for me to troubleshoot in the moment.
Okay, so now, and this is happening a little bit later, right? This is not happening in the room. This is in that quiet place, that special secret place that you know about in your emergency department where you can give feedback privately. So now you've had some time to kind of think it through. What might you have done a little bit differently?
I've been thinking about this a lot, and I think I could have maneuvered the scope a little bit better, and maybe had a backup plan in mind when things didn't go well. I thought I had one in mind, but I don't know if I verbalized it, and it kind of just fell out of my brain in the moment.
Okay. So let's break that down a little bit more discreetly. When you say you could have gotten a better view or done things a little bit differently, what concrete things would you do differently?
Yeah, I think just inserting the blade in deeper and not being shy about doing that sooner. I think she just had a lot of tissue, so it was really hard to see anything. And honestly, I think I just panicked.
Yeah, so what I saw happening was that I agree with everything you just said. What I was seeing in real time was that you were actually just very shallow.
Yeah.
Right? And then once you realized you were shallow, you actually, when you advanced the scope, you had a great view for like a few seconds. I got super excited that you were going to get that tube. And then it changed again. What did you see happen there?
Yeah, the chords were there and then they weren't. I mean, I think I just went back to the basics of, aren't you supposed to insert the Mac blade into the vallecula? And so I thought my initial view, I just wasn't placed in the right place. And then once I tried to maneuver it, I just lost the view.
Yeah, so that was a super floppy epiglottis. And okay, learning point from that, right, is once you get the view, take the view. Don't lose the view, even if you're using your Mac as a miller. Was there anything else that you could have done besides that might have made your view a little easier?
Yeah, I mean, I think we definitely could have repositioned the patient maybe a little bit better once we realized that the view was difficult. And then in my mind, I could have asked for a burp and just have some other assistance.
Like someone in the room kind of.
Got it. Yeah.
Yeah.
And just see if that would have helped me with my view.
Okay. So I think that's plenty to think about with the positioning and the view. What about, you mentioned another learning goal, which was backup airway.
Yeah.
Tell me about kind of what you would have done differently about your backup and your prep.
Yeah, I think maybe just verbalizing it out loud would have helped. I think we go through these intubations and it's always the routine, bougie, BVM, and I think making sure all of that equipment is readily available. I don't know. I just felt like we were just scrambling the entire time.
Yeah. I'd say that I think verbalizing the backup plan out loud to the whole room would be really super helpful because it wasn't just you. There were kind of multiple people in the room that seemed to like the BVM wasn't quite ready to go. The bougie wasn't clear to everybody that was going to be the backup plan, right? Yeah. So some kind of timeout or something like that in advance so people knew what we were going to do next if things weren't successful and normalizing that.
Yeah.
Yeah.
Yeah, I like that. I think checking all the equipment myself and just ensuring that we do a timeout might be a good thing to take forward. All right. Was there anything else that you noticed? I think those are kind of the big things that I've been beating myself up about in the last hour or so.
I think that's plenty. I think if you take all that away and integrate it next time around, that's going to be plenty. So I guess let's just kind of step back and just make sure we got a plan from kind of this episode, right? So that we don't lose any of the learning. Okay, what will be kind of like your take home points?
Yeah.
Things you're going to read up on.
So I think the big two that are sticking out to me is be more intentional with the laryngoscope and manipulating it, and not to be afraid to advance it or reposition it if my view's off, or ask for help. So the burp, the external pressure, if needed. And then I think I really like that idea of performing a timeout before doing an intubation if we have time, and just making sure all the equipment is available. Everybody in the room is very clear about what my backup plan is going to be. And just have a formulated plan so the room is also aware and can assist as needed.
Okay. And cut.
And scene.
Yeah.
I know, right? So any thoughts or reactions on seeing how that played out? Obviously a little bit scripted, but I do think that does really symbolize how a resident or a learner might feel afterwards, and have some time to debrief and really pick apart what maybe could have gone better in the room and start developing some of these plans on their own. Thoughts, reactions?
Ben.
Where do you stop with this, right? Because this, there were so many things that went wrong during this intubation. Like, do you cut it off? Sometimes I'm like, they're probably only going to take like 2 things from this, so like I have to cut it off at 2. Do you, if they're really going and you feel like you're having a good discussion, do you let them keep like list all the 10 things that they did wrong?
It's a great question, and if you get into the direct, I do a talk with ACGME on direct observation. There's some really good literature around this, and it gets back to the whole cognitive load piece. Sorry. It gets back to the whole cognitive load piece, and there's good literature around direct observation. If once you've seen 3 things to give feedback on in any one conversation, that's plenty. That doesn't mean to say that you can't come back. And if there's more to be had there at a later time, come back for kind of round 2. But yeah, otherwise they're gonna tune you out, and it's gonna have diminishing returns.
I think to your point, Ben, also when Sarah and I were going through the video together and picking out all of the learning points, I think we came away with like a handful. And so there's a lot of different nitpicky stuff that we could have gone the technical route or just like general preparation for a procedure. But I think, again, just taking home 1 or 2 salient points of there's a lot here, but these are the 2 concrete things I want you to focus on the next procedure. And then there's always learning points that they can continue to develop as they have repetitions.
Yeah.
I just love how you're able to, I mean, it's simulated, right? But I don't get that many like psychologically safe conversation for somebody who's truly like struggled and being able to open up. So you modeling that, like this is what excellent looks like. Like the challenge for us is then how do we create that in each of our environments?
Yeah, that's one of the reasons we created the script, and we mapped it back to the A, the D, the A, the P, and the T, so you can see how you can do that kind of streamlined. And then the second A doesn't have to be very long if you feel like you've kind of covered your points. So feel free to kind of adapt that for
Play around
for
with
your
it.
needs. Play
Yeah.
around with it.
This is Jody Jones. What happens, so you have a learner that was attentive to their mistakes. What happens if you have that learner that was like, oh, everything went great, it just took a little longer than it's supposed to? That's the harder feedback to give.
This is what, so one of the key things is you want to make sure that you have done, this isn't, you want to have a bit of a relationship with your learner so that you've had a chance to have a kind of a feedback conversation, and you normalize the feedback conversation. So this isn't the first time they're doing it with you. Because once that happens, you can say, okay, so it's clear that there are certain things about this that did go well, but I'd like to share with you some observations that I have about some things that you could do better next time that will make you much more effective, because I know that your goal is to be a great resuscitationalist, right? These are a couple of things that I saw. List what you saw, the discrete behaviors. I noticed that you did not go in very quickly with your laryngoscope, and it took a while to see the chords. I also noticed that it wasn't clear what our backup plan was going to be about rescue airway. Let's unpack that a little bit more and open the conversation, because this allows the conversation to be prompted from either the coach or the learner. But you just kind of say, okay, this is what I observed, and get it down discrete on the observations. But you have to have that ready. You need to think about, what are my learning points for this learner going to be if they don't come up with them themselves. So you need to actually think it through a little bit to come up with a couple of good ones if they don't.
And it may be not the time for them to learn at that moment because they're still hyperadrenergic from what just happened. And so allowing them to kind of decompress a little bit somewhere, and then just ask them later on, hey, it's now a good time to check in with you about the intubation?
But you're right. Sometimes they don't know what they don't know. They're in that right. Sometimes they don't know what they don't know, and they're in the upper right. Right, and you need to verbalize it out loud and think through what you're exactly going to say. And if they don't hear it, sometimes you have to say it more than once.
Excellent. All right. And so ADAPT, you've heard about what it is, what it entails, and you've seen an example, a simulated scenario play out. And so we as medical educators love, frameworks, tools, anything that we can use to have a more structured approach with our learners, but also to enhance that interaction. But the ultimate question is, does this even land with learners? Do learners feel like this impacts how they take feedback, how they interpret it, and can they use the feedback that they're learning through the ADAPT framework and actually make it into an actionable goal for the next shift? And so this was a study published in 2018, and the authors were the creators of the ADAPT framework, and they had the same questions.
what are the residents' perceptions when implementing this framework, and do the residents feel like this is a better structure than prior approaches to feedback? And what they noted was that the learners noted a reduction in anxiety around the whole aspect of receiving feedback. And so, as you can imagine, learners have a lot of anxiety around the ask of feedback and the feeling of burdening faculty for the ask, and especially at the end of shift, burdening the faculty of, hey, how did I do? Can you think of examples? And can you give me specifics? And with the ADAPT framework, this actually provides a structured process for both residents and faculty, so it felt more normalized. It didn't feel as big of an ask for the faculty members. And interestingly enough, the learners noted that they felt like the faculty were less anxious around providing feedback as well. And so again, that structured process really helped both sides of this relationship. The learners noted that this was efficient. It only took a couple of minutes to prepare aspect of the Prepare for Adapt framework, and then it only took maybe a handful of minutes to actually receive the feedback. So it wasn't a huge time sink on shift either. And then they noted that they were viewing their faculty in a different light. So instead of viewing them in this hierarchical relationship where there's a unidirectional flow of feedback, they now started viewing faculty as coaches or as teammates. And this was viewed as more of a collaborative approach. And that they realized that the faculty were invested in this and in this together with them. It improved their self-reflection and goal identification. And as you can imagine, with iterative processes of using ADAPT framework on every single shift, asking the learner, what is it that you're working on? What feedback do you want? Really helps to push them also start to identify gaps between where they are now and what their ideal performance looks like. And so really encourage them to reflect on their progress thus far, and then really solidify that feedback in a plan, in that plan together portion of the ADAPT model for what they want to do, concrete actions they want to take to improve on their next shift. And it overall increased the amount of useful and specific feedback that they were receiving. And so this demonstrates that the ADAPT framework really can help residents recognize feedback, internalize it, and use it to create action plans moving forward. And so with all of that being said, we, even in this group of self-selected medical educators in this room, we all recognize that it's still very difficult to give every learner on every shift high quality feedback that's clear, specific, timely, and actionable. And so now I want to pose a question to all of you. What are some challenges that we as medical educators in emergency medicine face that prevent us from giving high quality feedback to learners? Think about the clinical environment or our learners.
A lot of times the shifts, oh, this is Abby, by the way. A lot of time the shifts don't line up. So like my off-service residents are trying to give me their feedback form or whatever while I'm still working on 10 more patients, and I don't really have time to sit down and give that. And it's just a barrier that I've noticed.
Yeah, so maybe the learners wrap up and maybe we're not, or vice versa. Maybe we're wrapping up a shift and the learners are still completing their clinical care.
Sure. This is Keith Ongarden. I think the timing of the feedback, whether you do it immediately after or at the end of the shift when everybody's exhausted and just trying to get out of there, you're wrapping the last minute things up. That can be challenging, just working it into the workflow.
Yeah, absolutely. So timing of feedback, right? How many times at the end of shift do you have 4 learners lined up and they all want feedback and everyone's exhausted and everyone wants to go home, right? It probably doesn't land as well.
The amount of learners in that relationship. So it may be my first time meeting them and I may not see them again for months to have developed that relationship. And so it's just, I have to very quickly get on my feet, like assess where they are and how well they're going to be able to take how I'm going to give it back.
Absolutely. Variability of schedules. Maybe it's the first time you're encountering that learner in the clinical space.
I think also the learner's readiness to receive feedback. Oftentimes I'll catch a resident in the middle of a string of night shifts, and they just want to get out. They don't want to take the time.
Absolutely. And I think that goes to the earlier point of, are those residents ready to or learners ready to receive that feedback? And are they in the right mental space, headspace to receive it?
I think following that is also like several of us have been burned with, you give feedback and then you get these like anonymous retaliatory feedback in your packet and you have like, who is that person? So you're like worried because like, what if the next time you give feedback, it's another one of those things that's going to affect your promotion?
Absolutely. We'll take one more maybe. Yeah.
Sometimes I feel like, especially like at a small community hospital I work where I only have one resident, like the complexity of patient, I don't know if it really challenged the resident to like actually do something that they viewed as difficult. So I feel like giving, like feedback on like the 6 drunk people you saw is not like anything that's useful for them.
I'm sure there's a learning opportunity there somewhere, but yeah, absolutely. Sometimes it feels like there's just not enough meat on shift to provide high quality feedback. Great. So many of the points, I wanted to highlight 4 challenges that we oftentimes face, and many of them we've already touched upon, but I really do hope to give you maybe a tip or two on how to reframe that challenge in your mind or how to overcome that barrier on your next clinical shift. So the first is time, and this has a lot of layers behind it, right? Time is a limitation for everything that we do in life. But the thing that I want to point out and discuss here is the most daunting part of the ADAPT model is the time it takes to directly observe a learner, right? That's probably something amongst the ADAPT, the ask, discuss, ask, plan together. That's probably the one that we feel less familiar with or do less frequently. And so what I really encourage you to do is invest that time up front with the learner. Ask them what they want feedback on, what they want you to focus on, and that can also help you be a little bit more efficient on making your direct observations of that learner. So instead of a medical student asking you to watch their entire patient encounter, maybe ask them, is there a part of that patient encounter that you feel like you're particularly struggling with or that you want to focus on today? And when they say physical exam, wonderful. That helps you hone in on observing them performing a physical exam on a patient. And to Sarah's point earlier, usually it only takes a couple of minutes worth of observation for you to really get good information to be able to give them specific feedback. And so now you've addressed the learner is invested in this feedback. You have a direction for your directed observation to give them specific feedback. So really invest in that time early on. And Sarah had mentioned this earlier on too, but I think one of the challenges is finding that fine balance of needing to directly observe the learner while respecting their autonomy. And I think investing that time early on can be really helpful in setting up expectations. So now that the learner has identified things that they want to work on, set the expectation of, great, now I'm going to, in your next patient encounter, observe you perform a physical exam so that I can give you specific feedback. So let them know that you're doing this in service of them and you're not just spying on them in the room. And then again, Sarah had mentioned this, it also welcomes you into the room and gives you that fluidity of entering and exiting in order to get just what you need in terms of your direct observation. So then once you step out of the room, you're handing back that autonomy, that independence, and that space back to the learner. And then variable shifts. So we had talked about this quite a bit, and we had mentioned earlier that for a resident to be primed to receive feedback and they view you as a credible source, there is some form of relationship that really does need to develop in terms of trust and safety and credibility. And so with our variable schedules, this can be really hard. Sometimes you're walking into a shift and that's the first time you've encountered that learner in that clinical space. But I really think the prepare to adapt model really helps standardize your approach, right? And early on, even if you haven't worked with that learner, you don't know what their, areas of feedback have been recently. You don't know what their strengths are. You don't know where their areas for improvement are. Bring them into that conversation. Ask them, what has your feedback looked like in the last couple of shifts? What do you want to work on today? Where are the areas that you really are seeking feedback today? And so this can help early on build trust and safety with your learner that can then help them be more prone and apt to receive that feedback at the end of shift. And lastly, transitioning more from a performance-based behavior to a learning-based behavior. So encouraging learners to kind of shift away from the feeling of needing to be right to that desire to improve. And so this is really hard. We can get in the weeds about intrinsic and extrinsic motivators for learners, but I do think there's some things that we can mirror on shift to really help them transition and focus on those learner-based behaviors. And part of that is, we had mentioned this before, but just transparency of why we give feedback, and then also normalizing feedback. letting learners know that we're not just singling them out because they're performing poorly, but this is a natural part of training, and this is something that we're doing for all of our learners on shift, regardless of whether they're strong, they're strong residents or learners who are struggling. And then the other thing I just want to mention quickly is praise the process and not necessarily the product. So if someone crushes an intubation, maybe instead of giving them a gold star and a fist bump, praise the process. I appreciate and acknowledge how you took the time to set up your equipment and how you stayed cool, calm, and collected while you were troubleshooting a difficult airway and implementing your backup plan. I think those two steps together really contributed to your success during this intubation. So praise the process, not necessarily just the end product. All right, so now that you've heard about ADAPT, we walked through the steps, you've seen it play out in a scenario, we're going to have you guys practice in groups at your tables and how to incorporate ADAPT and the coach approach in different learner scenarios. So this QR code, I think you already have it pulled up, but the scenarios are listed on this document, so easier to access. I'll leave it up here for a second for you guys to take a picture.
We have slides of them too, of the actual scenarios, just in case you're having technical difficulties.
We're gonna have to have 5 minutes for the scenarios each, or we need to each go to a table because there's not gonna be time for debrief.
Okay. And so the first scenario is going to be the incoming chief. So a resident who is a strong performer. And we really wanted to start off with this case because it is a contrast to the scenario that we role played for the difficult airway. And so this is just to hammer home that the ADAPT model, although we might use it more, we might seek more comfort with it in interactions with a learner who's having some challenges. This is still a structure that we can use with all residents, strong performers, middle of the road performers, and learners who are struggling. So we can go ahead and turn it over to you guys at your tables.
And we're gonna each come to a table and sit with you while you're just to kind of serve as a kind of a sounding board. Try to come up with some specific take-home, concrete recommendations for what this resident might do more effectively next time through the ADAPT lens. Just give it a go. We'll do this for 5 minutes, and then we'll go on to the next case, and then we'll do that, and then we'll bring it home. Sound good?
But I think we did find something during the test. Yeah. Because you weren't expecting it to be great progressive.
They all want to go to a lot of residents. I don't know what oh, it's the same sort of. So I think this is a great example of someone who knows a strong start. And you might not have confidence that you want to work on and making a shift, but at least the ground is open and trying to build people and learning your and a quick job. Introduce something that makes them happen about because there's so much journey else. So what would you do in this resident who is fine and open to turning back? And I noticed that most areas pretty strong kind of performance. For that interaction with the learner was got this thing. That's like, well, it might not be a thought.
They would probably say, well, the medical students just didn't seem interested. They found it that one second. That would be the resident perception. Just I did. Neutral, and then you would say, I was smart someday. I learned whole kind of basic
their question about differential necessity. About what do you think? I like that. You know, like, great by the level of the learner. Absolutely. That's motivation.
I would say simple, but something for common or the ones you comes you.
You're right. I mean, we have for the most part.
Aspiration. So you sort of normalize and say, you know, hey, I'm this. What are your thoughts? How do you level up? So you want to just normalize it. I appreciate you spending so much time. You don't want to feel like you're at the bottom of the muscle. If that's all.
Together. Then it's that much more fun. Something like the second one is better. Right. Initial. Like one month. I would think you would talk right. You know, like, you know, but you know, like 10 whatever the experience that you I was concerned about how can I help you feel that like even like how you actually like I'll work with you to actually look like find a goal. Things that I do. So sometimes this is the way that I like to go. Their like their goals is so that I think that's the part that this is it's not just the style, it's also to give it is there some other ways to bring that approach or other approaches?
All right. So we've looked at this now for a tough, kind of a softball, someone who's doing well. We're going to give you one more to think about that's a little tougher. Do you want to read this one out for me?
Yeah. So, as a contrast, we wanted to bring up something to talk about together as a group that can be really hard to give feedback on to people individually, which is communication. And so, this is a scenario, just to summarize, about you're working with a resident who one of your like trusted nurses comes up to you during the shift and they say, we need to talk about this person. They've been really rude. They've been rude to me. They've been rude to some other nurses. You got to cut it out with them. You got to talk about them. So you make a decision. Okay, I really want to observe this behavior. I don't want this to be anecdotal. It's not, it's not actionable. It's not specific. So I need to find something. And so you watch them, and you notice two different things. You notice that they interact with a nurse when EMS is dropping off a patient and say, just do your job and put them on the monitor like I asked. And two, you witness them talking to a nurse who comes up to them while they're working and says, wants them to update a patient. And they said, well, I can't do that yet. The results aren't even back yet. And then after the shift, that resident approaches you and they said, hey, can I get some feedback about the shift? And so how would you even begin to start a conversation with that? So if we could just take like three, I know this is such a big topic, but take a couple minutes to talk about how we might approach that.
And we're going to do this one a little differently because it's a little bit more challenging. Okay. Talk amongst yourselves at your tables about how you might unpack this, and then we'll debrief it as a group together.
I think this particular resident, these things are collective in this restaurant room. So it is very one of the things I noticed with this is like I wonder if it's make sure it's overwhelmed.
In those two situations. When they had a chance to kind of emotionally.
Okay. We just want to round out these discussions a little bit because we're at the end of our time, but we've really enjoyed having the chance to talk about this with you all. But just for the sake of time, I think as we've been talking together as a group, one of the ways you might approach this situation, I think as you're working with this model that builds relationships, is to start off this conversation with the resident, assuming good intent. And so if you let them know that this feedback comes from a place of wanting to help them develop and assuming good intent, then it becomes easier to have that conversation. And so saying, we've worked together before. I know that you're working really hard. I know that you want to be a good team leader. You had some learning goals, unrelated, other learning goals during the shift that you're doing great with. And so the biggest thing for me is I don't want you to feel misunderstood by the people on the team. And I know that it would be important to you to make everyone on the team feel good and feel understood. And so at some point it would have been good to preface before you do the feedback that I have a little bit of tougher feedback to talk about and give a little bit of a warning shot. But saying, I've observed these two behaviors with you. And because I know you have good intent, but I think some of these behaviors didn't come across the way you wanted them to. And so I wanted to explore a little bit with you about what your intent was with those communications. Do you remember that happening? What were you thinking? What what were you trying to accomplish, and having as much curiosity about the situation as you can. And then if you establish a good working relationship with them and try to approach it with curiosity, you can then circle back to discussing with them like ways to take that. And so I think this is important to talk about, because this is something that is not a never event. Like, this happens occasionally, and we want to be able to try to have a conversation with people even when it's hard.
This is very hard. Also, I can imagine there's several APDs or PDs in the room. This happens a lot, right? Like, nobody wants to tell that resident because they're worried about their evaluation, so they go to the APD or the PD. And then how do you then address that?
How do you address this when you don't observe the behavior, but you're getting the feedback? I think that's one of the hardest parts I've had as nurses tell me a lot of things, but it's hard to actually get the tangible examples when I don't witness it.
I think I try to communicate with nurses on that side too. So I'd say, thank you so much for telling me this. I'm going to be on the lookout for it. And then you try to, but like, I agree with you. I don't like to give someone non-specific, like vague feedback. And so that's where you're trying to find some evidence or some validity to put to it. Even if it's someone you trust, you can't say like, so-and-so said this about you. Like, it has to be, and if you're paying attention, even if it's something small, like you may be able to find an in with it. But yeah, I agree. I wouldn't give someone vague feedback that like you didn't observe too.
And I'll add, as a former PD, APD, what's that? It's I went in guns a-blazing early on to just nip these in the bud as soon as I could, and realized you just have to stop, pause, gather more data. And if it's not in writing, I'm not going to talk to a resident about it. You have to write it down for me, or I'm not going to address it.
So I'll speak to this because one of my professional roles is as an at-risk coach, and I do this with medical students, residents in my own and other departments, and at-risk faculty who have gotten feedback that they need to work on with high-stakes potential outcomes. So this is a thing that I do. Critical thing, and this is a tip of a much bigger iceberg, is having them have their kind of start to notice that there's a pattern in their behavior, start to help them weave that. But if it comes externally and they don't start noticing it themselves, it often will go over their head, and that's the reason why they're meeting with you in the first place. So this whole theme around kind of, I know you because you've met with them before, so you know what their goals are and you know what their motivation is because you've had those side discussions. What these reported behaviors, these are having impacts that are not consistent with your stated goals, right? They're landing in a way that you don't intend, right? So what we need to do for you to be more effective is to have you come up with a different way of performing that same thing that you intended that lands better. So let's unpack that and come up with a plan together. All right, so that, like I said, I'm making it short, but it's bigger, but you can't do it just in a vacuum. You have to do it kind of making sure that you understand kind of what they had intended. And once you explore that and you get a better sense of what their motivation was, then you can get to the concrete path. But yeah, thank you.
And the relationship is very key there.
Yeah.
So as we're trying to summarize our learning points about this feedback model, the biggest things to remember are it's a collaborative model to try to prepare your learner to receive feedback, check in with them about how they think that learning goal went, tweak the learning goal a little bit, add things, modify, and then come up with a plan to work with them. It's a model that reduces anxiety both for the person giving the feedback and the person receiving the feedback. It helps people develop a tool for their own personal introspection, and it makes feedback more targeted and specific, and helps develop learners become more like self-motivated, master adaptive learners. So we're excited to share this with you guys. We hope you try it out. It's okay when you're having these conversations if it feels a little awkward at first. A lot of new things do, but you all are going to be so great. Thank you.
All right, thanks everybody.
So now we're gonna try to incorporate some AI stuff in what you just learned, and so you're gonna do some more work.
So we promised a lot of AI integration. This is your chance to kind of put some of that to the test here.
Yeah, so we're going to task each table with a little bit of a project. We're going to spend about 5 minutes working on it, and then we're going to discuss your process and have you report back. And as we're utilizing AI, remind you of a couple of things or teach you a couple of things maybe about AI. It's really about prompting and the way you develop your prompt and iteration. So usually the first response you get isn't really what you want. It's getting there, but it's not there yet. So we're going to iterate on this as well. And we're just going to assign you tasks to do. So in the back, we're going to do generating topics for feedback and goals for the day for shift performance. So this would be the resident who comes in and says, you know, I want to get, this was me this last weekend, I want to get a float of pacer today. I'm like, okay, that's not a goal we can promise is going to happen today. So let's come up with some better goals. So you're handing the AI to your resident to help them generate goals for the day. And you can make up a fictional resident who has whatever problems you want them to have, okay? And then for this table, we're going to do feedback. So it's a faculty member who gets criticized for giving unhelpful, harsh feedback by their residents. And I want you to use AI to take a harsh piece of feedback. So write something in a very harsh tone and have feedback soften that and make it good, constructive, formative feedback for the resident. And then this group, we're going to do some bedside teaching tools that you can utilize for the day with your residents. So you're like, I went to this great education talk. I'm drawing a blank on the things they talked about. Help me come up with some bedside teaching tools and tricks that I can use for the day.
And you can call back to some of the stuff earlier, how to teach during times when the department is busy, add some extra challenge in there and see if the AI can help you work through that. So we're gonna have everybody take out at least one computer at their table, log into your favorite AI of choice. You can use Google, you can use ChatGPT, doesn't matter.
And you'll get enough free prompts to be able to do this project easily.
Yep, you can use your phone and see what you can come up with. See what interesting answers it gives you. See what you find most helpful about some of the prompt engineering, and then we'll have everybody share in a large group setting here in just a few minutes.
We can maybe let you run the second part. Maybe listen to the share like if it took me wrong direction. We'll just go. So we can just probably doesn't make sense. So okay. Just tell people to break as they need to, because if you need a bio break, just take it. Yeah. All right, we'll go a couple more minutes here and then we'll report out. Something over here smells like street tar. What the fuck asphalt is? Somewhere in this That's what we
Yeah, no, right.
So when we go into the AI gone wild, I'm going to. I want to just start with my. Can we go click on my sidebar there? On the sidebar there. Scroll. Can you refresh this page? Click on that, but I don't think.
Oh.
Clearly, my son's using my account right now for a programming project. I'm like, what is this? I'm looking.
Yeah.
It's finals week or something like that. All right, one more minute.
All right, if you guys want to wrap up here, get in a few last comments or last prompts to try and finish up what you're doing here. We're going to bring everybody back and share some lessons learned. All right, so I think it's probably a good time now. We can sort of bring everybody together, and I'm curious to hear from the groups, even in this short exercise. Do people feel comfortable sharing? Tell the large group the topic that you guys were working on and how your experimentation worked out, things that worked well, things that maybe didn't work well. What did you guys find so far? We got microphones that can roam around. Yeah, how about the table in the back? What did you guys work on?
Hi. So we were using Claude because I've been playing with Claude lately. But the most important thing is we iterated on our prompt. We had an original prompt about just, like setting goals, what you had kind of said. But then we got much more specific about where this is an academic center, where this is a junior resident, we're in the high acuity area today. And it gave like a laundry list of like all these kinds of things you could do. And then we kind of just talking amongst ourselves as if like, this is a culture where we're not really giving a lot of feedback and not really doing a lot of, observation. And what else were we saying? We're not doing a lot of, we weren't doing a lot of goal setting. So it came back with a much more like simple structured list, like it actually created this thing that I haven't heard of, the 3-2-1 method. 3 things the resident wants to improve today, 2 skills you want to observe, and 1 critical feedback commitment for you by the end of the shift. It was like, I don't know if that's a brand new thing that it just coined, but it was.
You heard it here first.
Yeah. Something we could remember and refer back to by the end of the day.
Yeah. So I think some great stuff in there. It sounds like iteration really worked well, and then increase specificity. Tell it exactly what sort of environment you're working with, what sort of learner, and the more details you're able to give it, the better response it's able to generate back in terms of something actionable that you might be able to use on shift. So that's awesome. Would you guys use it after all of this to help generate goals for a misguided learner, perhaps?
Yeah, I mean, at least for us, it would give us, a framework where to start, so that resident that is doing everything right, what is one area that they can potentially improve on, so some general themes.
Yeah, absolutely. It's sort of a brainstorming exercise, a good idea generator. So that's awesome.
Can I ask any pitfalls or anything unusual that came out of this where you're like, whoa, that's out of left field and we're not going to do it? Or was it pretty? These guys have one. Okay, I just want some examples of that too.
We asked to just give some examples for overly harsh feedback, and that conversation was a mess. You completely confused the family. If you can't handle breaking bad news, maybe you're not cut out for emergency medicine.
So you're too nice to actually have harsh feedback. So you had to ask the model to give you examples. Okay.
But we also got some good.
Yeah, and we also were just very specific in our prompt. We tried to kind of just give honest feedback of like a difficult airway example. And then, it spit something out and it still felt a little harsh to the point of, adding back in, make it nicer, warm up the tone, make it shorter so that it's more actionable. And then kind of by like second or third iteration, though, it was something that I would find usable for an evaluation.
Can you read us your
absolutely.
Maybe where you started and what you ended up with?
So started, I want to say that I would not have said this. I have difficult feedback to provide a resident. They were terrible at performing an airway. I've been told to be nicer, but they didn't prepare well and they couldn't identify landmarks, no backup plans, seemed nervous. It was terrible. And so the first one was really long and I said, make it shorter and nicer. And it said, I wanted to give you some feedback on the airway attempt. I know it's a high stress skill, especially early in training, but there were a few areas for improvement. It didn't seem like you were fully prepared. You struggled with identifying landmarks, didn't have a clear backup plan. You also seemed nervous, which is understandable, but it did affect your performance. I recommend reviewing airway anatomy and practicing in SIM to build confidence. Everyone has rough cases. It's important to use them to grow, and I'm here to support you in that. And then kind of the last version after asking nicer, warmer tone was I wanted to share some feedback with the airway attempt. I know these situations can be really stressful, especially early on, and it's clear you were trying hard. That said, it looked like you were a little bit underprepared and there was some difficulty identifying landmarks and having a clear backup plan. You also seem nervous, which is totally normal, but with more practice, your confidence will grow. I'd recommend running through some practice scenarios in SIM. This is a tough skill to master and everyone has a learning curve, but you'll improve quickly with more preparation and experience, and I'm here to help.
Wow. So calling back to our educational alliance, a lot of supportive language in there. But yeah, I mean, obviously you're not going to be reading from your, tablet what your AI generated feedback is at the end of shift. But, if you were having trouble coming up with some effective language to use, I could see something like that being a good, again, kind of brainstorming exercise or something to get the juices flowing. Did you guys? Absolutely. Yep. Because sometimes it is easier to have these conversations in person than it is to actually write some of that down. So that's great.
I do use it for simple. So when we do end of the shift evaluation, when I'm charging my car, I dictate this, and then Grammarly, I have like a keyboard in my phone that actually just like changes it to a nicer tone, so that then I can include that in the actual evaluation.
So what I noticed is that AI is trying to put all the onus of the feedback conversation on the faculty member, right? What I love about what we practiced today is that the learner can take on a big chunk of that themselves, and so it really kind of evens it out a little bit, and because they help design it, they get more behind it. So use that to help you.
Yeah, and we didn't plan this, but I use a combination of what you just said. So I asked for permission to record feedback sessions. And so I record it with what we're using today, and then I incorporate it into AI to then give the feedback in our feedback online form to the learner. So I don't have to talk about it and type it.
That's awesome.
And it's a dialogue.
We're using ChatGPT, and because we weren't quite sure what the prompt was, we actually just were spitballing, and it recorded what we were saying. And so it said, you know, it looks like you're trying to develop teaching tools and training content in a clinical setting. So it was just random, and it just gave us a clinical setting that it made up about a resident, a busy shift where a resident was being short, and it came up with some. So, you know, we're trying to create this tool. It was like, would you like help creating a structured teaching module or reflective exercise or a scenario prompt? And so we told it that we wanted a scenario prompt, and then it gave us one about the ED. And it gave us a prompt for discussing the shift. So the scenario prompt that it gave was, it's a busy shift, waiting room is full, a senior resident is leading a team that includes nurses, medical students, and a new clinical tech. During the shift, the resident gives short, dismissive responses to nursing questions, avoids eye contact, and interrupts the team during huddles. A nurse then expresses, like what we did, frustration, saying that they feel disrespected, and the resident is treating everyone like they're in the way. And so then it gives us a prompt for discussion. And I mean, I must say, I was very impressed. I was very surprised that it, you know, it was pause, reflect, impact assessment, and then long-term learning. But it did put the onus on the attending or the senior leader, which I think is something that we discussed today. That's not the only way to go about it, but I was very impressed.
Yeah, and I think you emphasized one of the things I kind of wanted to close this exercise with, which is, boy, there's really no aspect of what we're doing in terms of clinical teaching in the emergency department that this doesn't touch on, right? You know, you could have it develop a curriculum or help you, you know, flesh out a curriculum. You could have it help you, you know, with feedback at the end of shift, with goal setting, you know, all of the different dimensions of kind of what we do could be impacted by this, right? Depending on, you know, level of interest, your, you know, ability to sort of interface with the technology. So strongly encourage you to continue to play around with this. See the spots that it might be helpful for you, because it might be something unexpected like goal setting that you're like, I never would have thought of this for you know, a learner that seems kind of unplugged from the clinical environment. But maybe all that's needed is to sit them down with ChatGPT and say, hey, listen, it seems like you're kind of having an unfocused shift. Let's see if we can you know, come up with something that really rings true for you. So play around with this on your next shift. That's sort of what this exercise is really all about. But we also should transition from there to, I think, another important aspect of this.
I'm just going to do my
real
quick, and then we'll go into that.
Oh, yeah.
So this is just to show you kind of what we've been working on, or I've been working on with my recording. So this is the first half of our conversation, talking about the conversation that Sally Alvarez is leading. So clearly it doesn't get everything right, but this is the recording. So
Sally is here, actually.
Sally's here in spirit.
Channeling us.
So this is just a recording, simply using the voice memo app on my iPhone. It then automatically creates this dictation. So this is everything I fed it from the first half of our conversation. So it's a pretty extensive dictation.
So you uploaded directly the voice.
So I just
MP4
uploaded it.
into
The app makes the dictation for you.
Cool.
So it already converts it into text. ChatGPT won't do audio conversion in and of itself. You have to use a secondary system for it, like Otter AI or something like that. So then I just said, make a bulleted summary of this education session. And then, so it made our session overview, but it really got into like the nuts and bolts of how the session was going to be run that day. And it's like that, we didn't want that. So then I said, I liked what it gave, but it didn't give enough details. And then it got into too many specifics. And so I asked it to focus only on the education aspect of it. And then it said it wanted to asked if I wanted it to make a faculty development guide. I said yes. So this is the part that I found really interesting, in that, like, when we talked about the conscious competence matrix, it actually, without seeing the slides and just hearing us talk, it made the matrix for us. So just really cool little thing that happened. One of the complexities of this is, while that happened, if I asked it to generate this again, I might not get that matrix again. I might, and I'll get a total, because again, it's about optimizing what it thinks the next thing should be. So every time it rolls the dice, it's going to give you a slightly different answer. And so that's just something to be aware of. So I just wanted to show that real quick, and now we'll go into cautious tales.
Absolutely. So important to be aware of, the limitations of any new tool. We're all excited about the possibilities here, the ways in which this could potentially, enhance our learning and really, make things much better and easier for us. But there's some downside potential here too, right? And I think we should be sort of explicit about what that is and go through some case examples so people can be aware of what to look out for. So, this is maybe one of the notorious examples that sort of hit the lay press of, recommendations from AI that are maybe not quite on target. So, how many rocks should a child eat per day? One small rock, it turns out. They're a good source of vitamins and minerals. Maybe not quite the right synthesis of that. But you can see the date associated with this in small text along the bottom. This is from May of 2024. The other one that I really liked was this one, which is your cheese isn't sticking to your pizza. What do you do about this? How do you get your cheese to stick to the pizza? Well, a little bit of Elmer's glue actually added to the sauce really helps with stickiness of pizza. And I also liked that somebody actually did the detective work and tracked this down. Where would AI get this idea? And it turns out that the eminent scholar Fucksmith from 11 years ago posted this comment facetiously on Reddit, and it became part of the collective wisdom of AI after that. But you're going to say to me, okay, these are funny, but these are from last year. This is ancient history in artificial intelligence and large language model terms. Maybe all of the issues with AI have been ironed out. Now it's ready for prime time. But while they've made some progress in stamping out issues like questionable data sourcing from Reddit, other issues like just plain making stuff up or AI hallucinations have been harder to stamp out. This article is from earlier this month, about a week ago, where it says, as the AI continues to develop new capabilities, this probabilistic model is getting more troublesome. It's creating more nonsense out of nowhere, and they're not sure what to do about it. The companies don't know why, which is not great. And it kind of ties into this idea, which is that, even the folks who are supposed to be in charge and the most knowledgeable people about this technology really don't know exactly how it works. They know that, it makes connections, it creates these probabilities, but having a sense of exactly, what it's going to do next, not so much, which makes it really hard to troubleshoot, makes it really hard to debug, and it makes it really hard to implement safeguards around, hey, is this knowledge that it's spitting out true, objectively true or not, and is it safe? So we're going to see some examples where maybe it gets some of these things wrong. And, raises the question of, do we really just have a fancier, slicker version of this? People may remember this from long, long ago in the AOL era. We've had chatbots that could kind of talk back to you in some form for a long time. This was never super smart, but it kind of could say things that made sense to you sometimes. So is this really just that in a fancier package? And you be the judge. So all of these examples, to avoid the ancient history problem, are taken from me personally in the last month using some of the most popular models. I tried to, not discriminate against any particular model or be too harsh on anything, but this was all done by me personally in the last month while I was bored at the VA. So, this is SAEM. Why don't we have large language model summarize the latest excellent SAEM GRACE guidelines covering alcohol use disorder and cannabinoid hyperemesis? Should be very doable. One of the things large language models do best is they summarize really well. So it would like to tell us that the GRACE guidelines stands for the Guideline Recommendations for Alcohol Care and Evaluation. Wait a minute, that seems like it might not be right. Oftentimes, large language models, as we mentioned at the beginning, are not necessarily aware. They may not have incorporated the latest most late-breaking information. Because it never pulled the GRACE guidelines into its knowledge bank in the first place, it doesn't really understand what GRACE is, and you can imagine that the summary that it generated has absolutely nothing to do with what is actually in this paper, because it tells you that the source that it made up for this is just an article that does not exist in JAMA. Looks nice, it's a great looking citation, but it has nothing to do with this, which is the actual GRACE guideline, which, as you might imagine, was published in Academic Emergency Medicine, not JAMA. So if you're looking for a recommendation or a summary of this article, you're going to be way off, and it's going to look, boy, pretty darn good.
I just want to
looks
emphasize
great.
that these are real searches that you did.
Yes.
Like real creations you did. This is not like you made this happen. This is just what happened.
I just screenshotted what came up. But this looks like something you could take and present at a conference, right? It looks super polished and professional. Let me give you this summary of this article, and oh, by the way, no, it's not correct. It's also happy to bullshit about things that just don't exist. So you could argue perhaps I shouldn't have been asking it to discuss the management of opiate-related tachypnea, a phenomenon that is non-existent in the first place, right? Don't lead it along. Don't encourage it to give bad results. But boy, what about a medical student who might not have their pathophysiology straightened out yet? Many of them use this large language model, Open Evidence, which has the New England Journal, prominently displayed along its, top banner. People really look at this as a source of definitive truth and definitive evidence these days. And, how can we teach medical students that, boy, this is maybe something that needs to be taken with a large grain of salt, just like everything else? What's up? Or Elmer's glue, that's right. It also will have a tendency to overstretch findings. Asked it about arthralgia for statins, and it turns out there really isn't that much about arthralgia for statins, so it kind of took what it does know something about, which is that statins cause a lot of musculoskeletal pain, and says, well, arthralgias are basically the same as a type of musculoskeletal pain. I'm going to say that approximately 5 to 10% of patients taking statins have arthralgias. That's not really objectively true. It's kind of taken something it knows and extrapolated into a domain where it doesn't really make sense. So could really get the wrong impression about that very quickly. Also, it's not going to necessarily synthesize things the way you might expect an experienced clinician to do. I asked it for some recommendations about sedating a very sick-sounding 95-year-old patient who needs a hip reduction, where an experienced clinician might be like, wait a minute, hold the phone. This seems like not a very good idea. Whereas the AI model says, let's give this guy who's 1 million years old some ketamine and some benzos. How about that? Again, does it have some, ideas that are reasonable? Potentially, but you have to be very careful with kind of following this to its conclusions all of the time. It's got some questionable judgment sometimes. I asked it to give some guidelines on how to perform an appendectomy in the emergency department, and I liked particularly that it told me that the recommendations that it was providing me was supported by the latest clinical guidelines, which it most certainly is not. To the other AI's credit, the other ones were like, absolutely not, you should not do that. That is a very bad idea. But I think this was Perplexity that was ready to go and talk me through my ED appendectomy. It also doesn't necessarily do the job that you would hope that it does in terms of summarizing things. We think of the ability to synthesize and summarize as a sort of core ability of these large language models. But you can see here when asked to make a judgment about superior treatment, it's willing to put its coin down that compazine is a superior treatment to Reglan, but will then spit out some data that essentially refutes its own recommendation right here in the summary. So something you have to watch out for of is its final synthesis congruent with what its sources are actually saying. It's happy to spit out incorrect citations. So you saw the one earlier where it made up the GRACE citation. Most of this is actually correct, but For some reason, it felt that what I really wanted here was a DOI link to be able to directly access this article. So it made one up. The clinical practice update, absolutely answered my question and related to the guideline on diverticulitis that I was looking for. But for whatever reason, it didn't have a link to it. So it just linked to this random editor's note from gastroenterology instead. So you have to watch this like a hawk. Even if it's partially correct, it may not be entirely correct in the way that you would hope and need it to be. So what does the future of this look like, right? I think there have been two potential futures that have been articulated with this. The downside future for large language models is that this turns into a garbage in, garbage out scenario, right? So people are going to continue generating all of this AI content. The AI will then continue to sort of suck this AI-generated content up into its model and then use large language model-generated content to generate more large language model content. And it's going to be this sort of non-virtuous cycle of further and further garbage that's generated, and everything is basically large language model content going forward. Maybe, we don't know. The other idea is that this is just going to continue getting exponentially better. Things are going to be more capable. It's going to be able to iron out more of these errors. And what we're seeing now is essentially the tip of the iceberg. A year from now, these are going to be just phenomenally more capable and more able to take on all of the problems that we're dealing with. So we'll see. Stay tuned. It will probably be closer to one of these two. It may be both of these simultaneously. So what are the solutions here? How do we deal with this? One of the things we haven't talked about is these kind of purpose-built GPTs. So rather than let it sort of suck up all of the whole world of knowledge, what if you say, hey, you know what? We're going to say, just look at these particular reliable resources. Maybe you've got a GPT that's just focused on emergency medicine textbooks. So when you ask it to pull knowledge, when you ask it to summarize, it's only going to pull from what you consider to be the most reliable sources, and it's not going to pull something about Elmer's glue off of Reddit. So this may be something that we see more of going forward. There are already a lot of these out there. This is a particular research-related one that can help focus and hopefully help, generate some of those more reliable answers that we're looking for.
And I'll add that you can make your own. So you can go on ChatGPT if you have a subscription. You can take Tint and Alley's, cut the binder off, scan the whole thing in, and have your own private Tint and Alley reference through ChatGPT. You will be breaking copyright, but you can do it.
That's never stopped these AI companies.
That's
before.
true.
There's also the idea of hot versus cold. This idea is sort of how creative do you want the large language model to be in generating its response? You may want to turn your settings down to very cold. Please don't be creative or make things up. If you're low confidence, just don't generate something. So that may be of some use as well.
Can I just add to that?
Yes.
Sorry. What I would suggest if you start using GPTs a lot or LLMs a lot is that you create a list of the prompts that are effective for you, and you create prompt scenarios where I use this set of prompts. Otherwise, every time you type something in, you have to start from scratch. So once you start finding some prompts that get you what you want, save those prompts.
The tabs for Google Documents is helpful for that for me. So when I work on a project and I use like AI to help me, I have a separate tab for the prompts that I'm using so that in the future I can go back to it.
But I think the ultimate question is this, right? Can we teach our learners, as a part of our own thinking about artificial intelligence and large language models, to be responsible, cautious, and skeptical consumers of this technology? Can we help them separate the truly useful and helpful abilities that this has from the potentially misleading and deceptive? So I think a core competency with this for educators to think about going forward. We're going to skip over questions and move to the next section here. Thank you, guys.
Whole stretch.
If you haven't seen the first episode of The Pit yet, minor little spoiler alerts.
So this section of the workshop is to kind of just bring in like our collective experiences with some challenging learners. And so we have some examples here if you cannot think of one, but I can imagine many of you have even started asking those questions already. So I'm just gonna skip through some of these slides to kind of give you a flavor. There's the overconfident, again, spoiler alert, some of this, if you're really interested in watching The Pit and you have not yet done so, then you're gonna get some of the spoilers here. There's the med student who is really unsure about their competence yet. I know we tackled some of that flavor already here. There's a med student who is very avoidant because their mom is a surgeon and they're really trying to like not engage because they're worried that you're going to connect them with their mom. There's also the surgeon who has like very specific things that she wants to do in the emergency department, and she has her flavor as well. And there's also the mature and competent residents, but comes with a history. Things that perhaps like they're having some shame-based reactions whenever they work with us in the emergency department. And of course, there's the competent resident with a secret. Some of you are smiling because you know what that secret is like. So what questions do you have? This is really more of our collective wisdom we can share with each other, and also the faculty can kind of give you some guidance of like, when I work with this resident or when I got this feedback from a nurse to relay to the residents, I really struggled. And so this is the time to ask us what those questions would be.
Any brave, curious souls? Or your own learners you would like guidance?
Nobody has any learners that they're challenged.
All right, we got one brave soul. There we go. Broke the ice.
All right, this is Keith Allen. So I guess in kind of the same line as an overconfident resident. So it's easy with learners like medical students sometimes and interns that, it's essentially a blank slate. When you have a more senior or seasoned learner that's maybe a second year or even more serious, maybe a senior resident that's going to graduate, and you realize that they have maybe a profounder misunderstanding of the way this is going. So for example, like you going back to intubation, perhaps their technique is totally off and maybe they're doing something egregiously wrong, but it's been, at this point in their career, you are just about to graduate, right?
They're 2 days away from graduation.
2 days away from graduation. So those ones where it's like, this is potentially psyche shattering, right? If you're trying to, correct this, how do you approach those scenarios where it's more of a seasoned learner?
How do you teach somebody who's like worked so hard over the past 4 years to develop the skills, and now they're so confident they're about to graduate, and then you're watching them, you're like, they do not have the skills that they need to actually do this right. Anybody?
I'll just throw out there again with my former PD hat on. If they push it at that point, it's too late. Yeah. And I've had 2 different residents that I knew weren't ready to graduate, and I wanted to keep them for another 6 months. And both times I attempted, the first one, the GME said, if they elevate this up, you do not have enough documentation to support your concern, even though the entire CCC agreed with me. And the second one, they just said, plain and simple. They didn't even go through the first round of like arbitration. It was just like, no, you don't have enough documentation. So your faculty will really hose you in these situations because they do not want to write constructive feedback for residents that reflects on concerning things. So you got to catch this 6 months before they graduate so that you can at least try to mitigate what's happening if you don't have the documentation to support it.
I also love the alliance, right? Like you've worked together for 4 years. You can also just, I go through this. This is the time of the year when you start working with this is the very last, I'm a nocturnist. It's the very last overnight shifts I'm going to be working with this resident. If I find something, I do hey, another way that I've learned how to do this, or I tell them my mistakes. This is the time usually when they're about to graduate and they're so nervous about making mistakes now because transitions are very hard, right? It's when we deal with a lot of imposterism. And so for me, I normalize a lot like, hey, can I share with you when I first screwed this up? Can I share with you when like, what happens? So I do the what ifs. Like, what if you're working with an intern now who did the same thing And here's my lens. Here's how I see it. I ask them for advice. And indirectly, I'm actually asking them to give themselves the advice. It's like, oh, so I noticed you did this. Like, what was going through your? So then, just giving them the awareness. I learned this from Sarah Williams. Like, sometimes they do certain things that they think, again, different intentions, but like you're observing, it's completely wrong. It's like, oh, I see what you're saying, but I see it differently. Can we both agree with that? And if they're not, I also just have to now accept that I am not going to be the very last attending that they're going to work with. This will come up again for them in the future. And there's also growth beyond residency. They will get better with this because it's either that or they're going to get sued. And eventually they're going to learn this somehow. I am not the only attending that will have to like pull them out on this. That's my take. Any thoughts from the table as well?
I mean, I think
it's not
that's
easy.
The point of I don't want you to leave here without the tool set you deserve, and let's work on that while we have time to. I had a resident when I was an APD who had a stroke 6 months before they graduated, and they lost proprioception with their stroke, and they had to basically relearn all of their motor skills without anything they had to do without looking at the patient. And I actually presented them at CORD one year, the process we went through to retrain all of their skills in the last 6 months. And she just sent me an email 2 days ago about SAEM. So,
What happens when they're like so nervous to take any risks because they want to get a perfect score? Those medical students, right? This is that time. We're about to get like the auditioners that they want to match with us. And so they're going to take the easy case. I want a suture. I want to get the chest pain. They're not going to pick up the super complicated patients because they just want to get a good grade right now. How do you then push them a little bit? Because you know that they're going to do it. They're going to be great. Oh, I saw you.
I usually start every shift by reminding everyone that they're here to learn.
Yeah.
And just remind them that, you know, if you knew everything, if you knew how to do everything perfectly, then there would be no point in residency. There'd be no point in fellowships. You just go right into it. And so it's okay if you don't know things. That's the point. Like, we want to learn together. And kind of remind them, you know, even as attending, I'm learning every day too. I learn from you all. So just kind of getting them excited about the learning rather than fearful of
I
getting
like
something
the focus on the learning environment and then emphasizing that it's constant learning. Yeah, for sure.
this is actually me to some extent right now. My daughter is an intern in my residency at the moment. And so we don't work together.
Yeah.
We deconflicted our schedules so that we're not in supervisor roles until she gets a little more senior, and then we'll probably do some shifts together. How about from the student perspective? You're our solo student rep. You want to share anything about your experience?
I think for me, like definitely like setting like expectations, but also just even if they do want a good grade, like maybe a portion, just like emphasizing a portion of that is what you already know. But I feel like, and hopefully you guys agree, like a good other portion of that grade that they want at the end is how did you receive that feedback and how did you implement it? And that's like another thing to point out to students is like, you know, you come in with this knowledge, but you know, that's only one small portion of the equation, but also emphasizing like how much did you grow at the actual rotation and how much did you grow during that shift?
Yeah. The clerkship directors hate me for this, but I also, I have a pause either earlier in the beginning of the shift or like halfway. I said, hey, I have enough information to write you a very strong evaluation. Can I just like, can we like acknowledge the fact that I'm just going to give you honors for today's session? And I'm now for the rest of the shift, I'm going to ask you a lot of questions because I'm at my best when I ask a lot of questions. And if you work with me, I will actually make you think. I want you to explain why we're choosing certain things. And they love that so long as they know that I'm not going to penalize them if they don't know the answer. And so that's another tip that a trick that I use with my style of teaching as well. Again, clerkship directors hate that because I'm like, everybody gets honors when they work with me. But at the very beginning, I tell them like, I have very high standards. I need you to meet that. Once you meet that, like I'm not here to like watch you for the entire shift.
Yeah, you let them play with house money after the first half of the shift.
Any other questions? What about like an off-service rotator or like a consultant who is just like, they bring in their presence and they're good presence, but sometimes it's like, it's not working with our dynamics. Like, how do you give them feedback? Do we have a responsibility to give them feedback? I'm seeing nods, but how do you do that? They're not your boss, or you're not their boss.
You
Ooh,
want to
say
expand
something?
on that?
I think it's a very delicate balance.
Right.
And it comes from a place of asking questions, building that relationship, having that rapport, but also having the conversation of, hey, when you come into the emergency department and we're in this situation, when you address us in this way, it makes us not a team. And instead it makes us that conflict. And we need to be on the same team instead of having different perspectives or, whatever it is.
Do you do that at the beginning, the end? Like, how have you navigated that?
Probably the situations I've had have had to be almost outside the room.
Yeah, for
Or
sure.
moments of like, I'm doing what I'm supposed to be doing, you're doing what you're supposed to be doing, but you need to stay in your lane in those moments. And if you're going to contradict me, it's not in front of the patient and it's not in front of my team. We can have that conversation outside the room, unless it's a patient safety issue.
Yeah. Sarah.
This gets down as you develop a reputation in your emergency department on off services as well as in the emergency department in the way that you are with the trainees, right? So when I'm communicating with another program director, I'm a former program director, but I'm communicating with another PD, I'm giving them positive feedback about people that are coming down and doing a great job as well, right? So the only news they're getting is not the bad news. They're getting a lot of positive news too, because they're not just getting the bad, they're getting the good with the bad. And, as much as possible, role modeling, like including the consultants kind of as team members, so that, and encouraging your residents to develop relationships like longer term. That's why we tend to have better relationships with the trauma surgeons than we do with folks that we don't work with very often, right? Because we've been in the thick of it. We know what their intention is. We know them, right? So we've developed a relationship. So when someone has an off day or one of their colleagues has an off day, you understand their context, right? So the more you can kind of debrief with your residents about those interactions and give them a little bit more context, I find that super helpful as well. So that just enables you to have the conversation so it's not super awkward.
I also love taking that moment to celebrate a lot of the wins that they do, right? Because then when it's not the biggest win, then you can pull them aside. Hey, can we talk about this? Because I really wanted like highlight all the wonderful things that you did there. But like, here's one thing that I've observed that I just want to give you feedback, because I've worked with you a lot and I really enjoy working with you. Here's one more thing that you can do to make this better in the future. I see a couple of hands. This is
Program directors
making
love
people,
getting that feedback from their residents. That's positive.
yeah. I do that actually as part of my gratitude practice. When I'm having a really, really tough day, I make sure that I find like 3 things that I'm really grateful for that shift. And I write their program director or their clerkship director or somebody. It's like, I just want to let you know. And it's not very long, right? But it's an authentic way of gratitude that also makes them feel good about that experience, because they know they've been there. It's also a really rough shift for them.
Yeah, I was gonna say, like, I'm one of the residents, but like we work frequently with like off-service rotators. Like they're usually alongside us on certain shifts.
Yeah.
And if I have a great shift with somebody or like consistent like great shifts and like I hear great things about them, I'll just email the program director and be like, hey, like we loved working with them. What like a great person to have in our ED, and like setting expectations early, but also making it so that like they feel comfortable going to like either the faculty member or like their residents around them, because like they're unfamiliar with the department.
That's
and it's
right.
like, are they nervous?
Yeah.
And like trying hard, like then, you can like improve that. And I don't know. I feel like it's been successful.
Yeah, for sure. I CC them also just so they know, because sometimes the PD or somebody forget to like let them know later on. So I just CC them so they know all the kudos, because usually when you CC them, then somebody else CCs another person. And so there's a big like flood of like acknowledgement for their work. Somebody else had their hand here.
I try to make it about the medicine. So I'll ask them, well, what are you thinking that I'm missing?
Oh, yeah.
And so maybe they're thinking about a disease process that I haven't thought about then. And so then it's just like, we're not talking about personalities. We're just talking about
I love it.
the medicine. And then when they're like, we want the MRI of the whole body, I said, well, how is that going to affect them today? Like,
Yeah.
I'm not saying no to that workup, but what is that going to mean for them in my emergency department? Is that going to change your disposition on
Yeah.
them? So I make it about the medicine and take away the personal aspects. And then if it's my resident having a problem with another resident, I try to step in to make it me, because they still have to work with those other residents.
Yeah.
So I say, you know what, tell me and I'll be the bad guy.
Yeah.
Rather than you being the bad guy.
Yeah. Any other thoughts on this? This type of feedback it's challenging because you have to maintain relationships, not just like with one person, but there's actually like sometimes you're in between and navigating the roles of you're an educator, you're the attending, and also you're the doctor in charge of that patient. Like those can be very tricky.
Maybe when I think of this, I think of a very particular scenario in our department like 2 years ago. One of our faculty and residents were reducing a fracture, and orthopedics just happened to walk by the room where this was happening. And they were literally like, wait, are you doing ortho stuff in this room? Patient's awake, not sedated.
Yeah.
They're like, you can't do ortho stuff without us. It's like that interaction doesn't get solved in front of the patient. They're like, hey,
Yeah.
we're going to come have a little conversation.
Yeah.
So mitigating their behavior, but then addressing it somewhere else is important.
Yeah. Certainly done that as well. You can't do a thoracotomy. I was like, you were not here. Let's talk outside. And then let the other team like finish. What about this? Like we work with residents and there's different growths, right? What happens when like during intern year or maybe second year, they really struggled. And now somehow they're labeled as that resident. But now you're like third year and you want them to break free from that. How do you navigate that? Has anybody experienced that? Right? Do you want to share your story? Anonymously, of course. Like hypothetically, there's this one resident. I'm a peer supporter, so I do a lot of hypotheticals.
Yeah, I was an APD and a PD for a long time. So, 20 residents a year. So there's been lots and lots of, So I think one of the things is to normalize it with the resident. And I say, you are certainly not the, I think I'm upfront with them and I say, I know you struggled, and for those few times, that something, then, everybody noticed things didn't go well. People remember for a long time, and it's not fair. But I say, you know what? You are not the only one. Every year, there are several that, struggle like you did, and, you've come such a long way. So I think normalizing it and just making sure that they know they're not the only one is the way to go. And then just telling them, look, you have to be patient. And you already said this, that one mistake, it may take 10, right? 10 interactions after one negative. Correct. And so just making sure that they know they're going to have to be patient, because they get frustrated. Like, I'm doing okay. How come no one's noticing?
Yeah. I struggle with this a lot, right? Because it's not even that they're struggling per se, but some of this is like the imposterism, right? So there's also, especially for underrepresented folks or marginalized folks in the group, I have noticed, like, even as a fourth year, I had this recent conversation. I was like, you don't have to prove yourself to us anymore. You're part of the team. Like, this is your family now. Like, you're not a sub-I anymore. In fact, you're going to be a chief resident next year. Like, so building them with that sense and letting them know that, like, I see what you're doing. You're still trying to prove to me that you're a great doctor. You already are. You're part of the family. I will work with you alongside, like pinpoint some of the many things that you're doing wonderfully. I think it's important. Sarah?
So just want to kind of pull back a little bit from the idea that the trainee has to shoulder all of this kind of, or you and you as a coach and the trainee has to shoulder this alone, because I've seen this many, many times where the halo horn effect is real.
Yeah.
And bias is real, and it's pervasive, and people don't even recognize what it is that they're doing. Once you have a trainee who's been labeled as either a rock star or a problem resident, every piece of feedback that you get gets viewed through that lens.
Yeah.
And I've seen a rock star resident, quote unquote, and a problem resident, quote unquote, say and do exactly the same thing. Exactly the same thing. And it be viewed as a uber positive for the rock star, and an uber negative and evidence of problematic behavior for the problem resident, right?
Yeah.
Whereas the, a spoken vulnerability on the part of the rock star is them with a learner mindset and them wanting growth and seeking out feedback. Whereas if a problem resident speaks about a vulnerability, that's evidence that they're a problem.
Yeah.
Right? And so the importance, and I was going to mention it at the end, but every single one of you is a medical education leader. Right? And so I would ask each one of you to go back to your shops and think about what structures you can put into place to safeguard and to mitigate some of this, right? To Jason's point being about when you're program director at the end of the 4 years and you are faced with the really hard choice of putting someone out there that you don't have data on, that you can prove that you want to keep them for another year because they'll be ready in a year, but they're not ready yet. What systems you can put into place that allow you to gather the data that you need. If you're not getting it, fix it, because you actually are the ones with the power to do it. And to this point about bias and rock stars and problems, faculty development around that, and not just once every 10 years, like on a regular basis with your CCC and with your rank and file faculty, because they're giving the CCC the data that the CCC is using. So anyway, I'll get off my, there's a lot that we need to do based on this because we can fix
and even the acknowledgement that exists. And so like we do this. I remember when we were doing ranking and somebody would say, yeah, they're just quiet, right? Like quiet oftentimes has a very different connotation when we're trying to like assess the learner. And I think being explicit about that and highlighting that they're actually like great, wonderful things that they're doing. They're just not the most like loud people that you would expect, that we expect for emergency medicine folks to do in general. So thank you for that point. Any other scenarios that you can think of? What about somebody who's competent? This is kind of like referring to the question of like, they're competent, but they have some secrets. Like for instance, like, and not the pit secrets, but like maybe the nurses actually hate them, but they're very confident and they get along with everybody else.
Or I'll throw out there, maybe they're sleeping with the nurses.
Sure.
Have had more than one resident involved in that scenario.
Yeah. Or sometimes the chief resident, because they're very good, like politically navigating the room, but in fact, they're actually very not sure about doing procedures. Or they're not, like their medical knowledge is not as strong, because oftentimes like what happens, like you probably have seen this, like as soon as they become chief residents, there's a thing that happens, like we just assume that they're very smart, they know what they're doing, when in fact, like they're probably the ones that need a lot more teaching for us, but we don't do that because we're like, yeah, but you're a chief resident. We just assume that you're good. Has anybody had encounters like that? How do you then navigate that? Because then you want to like not burst their bubble because they're like, they've just built this like ego that like, I am now a chief resident, I need to lead and I'm going to be the middle manager. But then they need to also learn how to do doctoring stuff in the emergency department because they have 1 year to do that. Ooh.
And if it's like our place, our chiefs work fewer clinical shifts than the other residents.
So they get less feedback because they're going to be chief residents. They work less shifts, and you're noticing things. It's like, ooh, they really need to work on this thing. How do you give them that feedback?
Coming out of residency recently, I think there's people that get in those roles and realize that is them. And so I think it's feedback that maybe they've already recognized, but I think being the attending to say, hey, are there areas that I can help you grow? Like, I know you still have a lot of learning to do academically in this next year, but you have a lot of these academic responsibilities. How can I help you make sure your educational, clinical focus is encouraged, and how can I make sure that's happening for you? Because a lot of times your chief residents are very introspective and know that's happening. They're not someone that's completely oblivious that they don't know these things. Hopefully they're not. Hopefully they have that insight. And so I think it's more just being that supportive faculty to recognize that and help them through it. But maybe
creating
I'm
that
wrong.
space to even ask them about that, because oftentimes, again, they're very worried. They want to prove to you that you picked the right chiefs, and especially the first couple of months when they're also kind of worried. It's like, well, I kind of need to learn to do this, like to be able to ask that, to be vulnerable. I think that's very
And
important.
I think remind them that this is the time to ask the questions. And if
That's
you're
right.
met with people thinking that you don't understand, say, I have a year left and I'm going to ask any question that I think I might need a year, might want to ask in a year.
Yeah.
Like, hey, what's your favorite go-to antiemetic when they have a prolonged
Yes.
QTC? What's your favorite, like asking some of the questions that maybe you haven't asked
Yeah.
yet. So.
I see your hand over there.
Yeah, so in some of the people who become chief residents were the people who ran for class president in high school and college, and so they're very personable. And then not uncommonly, we get somebody who's going a bridezilla, and so it's 2 years they've spent planning literally their wedding, because this is the time of year when people are going to get married if that's what they choose to do. And so they're very distracted also. And so that's been challenging. So one of them, I just had a conversation with her and talked about the ways in which a fellowship might be very beneficial for her long term, and just, acknowledged that she was kind of distracted in the last 2 years of her residency and she was also very involved at the national level with several of our EM organizations. So that was the way to encourage her to get more education and be in a more supervised role before she went out there. And she luckily agreed to do that, a fellowship. I won't tell you which one because you might get
Yeah.
It's funny, I heard bridezilla a different way, and we'll take this in another direction. It's the resident who spent all of their time preparing to be a chief and then didn't win the election.
Ooh.
And then they become like this monster in your residency.
Any thoughts on that? How do you then engage a learner who just got let down? Pretty big deal publicly.
I heard a
As a chief resident currently, I don't know how you engage them after the fact, but I will say, like, from experience at our program director has a meeting with all of us and is like pretty frank with us about like all of you would be amazing chief residents, but like I need you all to do a lot of introspection, and not about like whether or not you would be good, but like if you are not chosen, what you will do, because she doesn't want it to derail your like the rest of your residency. And it's pretty frank about like no one is a guarantee, and so like you need to think long and hard about like what that's going to look like when you're not selected. And if you can't deal with that, like if you're struggling with that already, you're probably going to struggle with that like in the moment, and so like maybe you shouldn't apply, type of thing.
Ooh.
I don't know that that's like the best way to do it, but it was pretty blunt, and it made me introspect a lot about like if I was going to be able to handle that rejection.
Yeah.
I think there's also something to be said for, finding some sort of alternative method of recognition or role. Figure out, what did they want out of being chief anyway? Was it, some kind of publicly facing thing? Did they want more responsibility as a third year because they were not feeling challenged in other aspects of their residency? So, we've often offered up like a sort of secret recruitment role. Hey, you're the recruitment lead for the year, that they can put on their CV. It shows evidence of leadership that they might want for their fellowship application or something like that. So try and scratch whatever itch the chief thing was going to scratch for them. But you have to kind of find out what that is first.
I saw a hand in that.
real quick, Ben. Did you make the phone calls this year? Ben is the new PD he's the incoming PD for Wisconsin. And yeah, the I forget what they call it in figure skating. The where you go to the cry. It's like the cry, or what is it? Where they wait for their scores in figure skating. I can't remember. There's a name for it. But anyway, it's like calling the Chiefs to tell them you did or didn't win is just it's the best and the worst day.
All right, so let's land the plane. There's a lot of questions that people have asked. We're learning a ton. And so I'm just going to ask you, if we can just kind of like raise your hand, what's one thing that you learned? Because you learned a lot today. What's one thing that you learned that you're going to take away and you're going to practice when you go back to your shop? Who wants to start? Alexis.
It's easier if you go first.
I know, it really is.
Yeah, so I'll talk about like the AI session, how like and like implement more of that into like giving feedback, even if it's written feedback, oral feedback, and even like kind of limiting using AI for specifically like management and those types of things.
Great.
Mhm.
What else? We're squeezing whatever else learning we've gotten here so you can hear from each other. Yeah.
I learned a lot about structuring such a workshop, and I really like the start with the gallery walk.
Yeah, for sure. We needed to make that at the very beginning because we're also not sure how many people will arrive on time. And so we need to make people move around a little bit and do something and play catch up.
I
That's the strategy
also
there.
liked the gallery wall, but I liked the really focusing on like when you're gridlocked, because I feel like sometimes that's probably a time that I let really great education time pass me by. So to have some good ideas for what I can do the next time that comes up is
We
nice
were
for
very
me.
intentional about hospital boarding because that happens with every emergency department. And so we wanted to make sure that we incorporated that in this session. So thank you for catching that on. What else?
Yeah, like utilizing AI, I think, to help like med students make goals for the shift. And also like when you guys talked about some of the pitfalls that can come to chief residents, I'm like, oh, I'll keep that in mind. Okay, cool.
I'm also incoming chief resident, and I think this most recent kind of set of slides, especially with the different types of learners, as we kind of anticipate a whole new class of interns with a variety of breadth of skills and experience, is going to be super helpful. And I especially love kind of your suggestion about kind of halfway through that shift saying, hey, we're done grading for the day, really testing learning for now, and creating that really safe space in the middle of a shift is something that I am really excited about trying out in the future too.
Yeah, it's helpful. I think when I heard from what you said as well as having that beginner's mind that like whatever they may have brought with them for that particular shift, you can always just start over because there's flavors of these different personalities in each of the learners that we have, right? And just figuring out and focusing, here's the one thing that I'm gonna do today, and not feeling this overwhelming thing that like there's 5 personalities I'm gonna like try to fix. Number one, you're not fixing anybody. You're just making a difference for that one person in that moment. And if you can just find that one thing that they can take away, you're gonna get that letter several years later, or that acknowledgement that like, hey, I'm at SAEM. They will remember you, and it's that moment that you're trying to give them when you're at the bedside with them. What else? Last one.
We'll go to.
It's kind of simple, but when she mentioned when you're in the ADAPT protocol, when you're giving feedback, just pick 3 things for them to focus on. Because I've made the mistake of wanting to tell them everything that went wrong, and it's probably overwhelming and too much, and they're not going to remember any of it. So stick with the 3 things like that I think are most important.
Remember the cognitive load theory, right? And also make it easy for you, make it easy for them. If you just pick 1 or 2 or 3, that's actionable as opposed to just this overwhelming thing. I gotta like download all of Tintinality in this one particular person on one shift. It gets very overwhelming. I used to be like that person. I was like, let me teach you everything that I know because like I don't get to work with you a lot, right? But then like a good resident actually told me, it's like, you know, there's many other attendings that I get to work with, and I hope to work with you again. And so you don't need to like give me all the things, the tips that you have right now. And so I've slowed things down for myself. Please go ahead.
Oh, I liked the preparation portion of the ADAPT model, to maybe talk about that at the beginning so that whenever you do start to give the feedback, they're already expecting it rather than maybe catching somebody off guard, and maybe they'll be in a better headspace to receive it later on rather than just kind of shutting down when you try to give that.
I love that. And also making feedback as just a part of the deal and not making this like a dirty word. And so the more you give it, and not just like on the bad stuff, but also the wonderful things, like if you start looking for the good things that they're doing, it's actually very easy. And just use the framework. It makes it easier for you to practice the ADAPT when it's a good thing that you're highlighting. And then you just like use it for the other stuff that you notice as well. That's what I learned a lot from the ADAPT framework, that it's not always reserved for the bad stuff. You can use it for the wonderful things that you see as well on a given shift. All right. Do you want to take it away?
I don't want to necessarily close it. I'll let you have the honors. But can we show the QR code for the shared document?
please, we would love some feedback to help make this session hopefully even better next year. Obviously, if you weren't there for any of the sessions or you don't want to give feedback on any of the individual sessions, none of the sections are required, but please, for anything that you did attend, we would love any evaluations that you
Can you
have.
hit your screen again? Hit your trackpad just so it lights up again. Is this a form or is this a blank document?
This is a form.
Okay.
Yep, a form with free response at the end.
Okay.
I will put this QR code in the handout as well, so you have it.
Yeah, what I would like is everyone here to drop their email into the document, one of the documents. Probably that form is your free comment. It won't associate your reviews with your email. That way I will send you the summary document from the AI that I'll put together. So I'll only send it if I get your email though. In the comment box on the form, the evaluation.
It's probably easier if they just put it in the handout.
Get a handout. It's not attached.
No, I didn't mean that. Put it in the handout link.
Yeah.
Wherever you put your email, we'll find it.
I'll use AI to find it. It'll probably get your email wrong, but
We'll also include, so you have the handout here. Again, take a picture of this. We'll include the summary based on the recording that AI will generate for us. And again, as much notes that we can share with you, we'll include it in this handout. So if you can put your email address there, that'll be wonderful. Any words from the table over there? Yeah, this is a great investment that you gave yourself to be here. We learned a lot from each other, from you. I will share with you that one of the intentions that I had when we were preparing this, Sarah and I were sitting down about the intubation, was I did this, my very first chest tube. I remember my attending. And I can even imagine like the room where I did the first chest tube. And 10 years later, she asked me, it's like, hey, LA, do you remember your first chest tube? I was like, yes, I did it with you. And then she's like, do you remember that you didn't even look at the chest x-ray? And my heart sank because like as a faculty, if I was that faculty, I would be like the one that would be like, you're not ready. You didn't even look at the x-ray, right? But the generosity that she gave me to not only take care of the patient, to take the time to walk me through the procedure, to give me grace for not even knowing which side of the chest I was going to put the chest tube, because it was not my patient. She just saw me as the intern who probably has not done a chest tube yet. And here I am 20 years later talking about her. I want each and every one of you to remember those moments so that when the first intubation that medical student, that resident is going to do with you, you want to be remembered 10 to 20 years later as well. And so hopefully today you got some learnings and some tips and tricks to be the best educator you can be. And if you mess up, that's okay. There's going to be the next resident, the next learner you're going to do. You can always start now. And so thank you so much for this time, the energy that you bring in here, and we look forward to seeing you again next year.